Guys. Good morning.
Yeah. Good morning.
I'm going to take just a second to take a look and see who all is in here so I can kind of keep an eye on attendance because I don't know all of you yet and it's hard for me to remember who was here and who wasn't. So just give me 1 second here. I think I got most people. All right. Okay, so this morning we are going to start with math. So I sent you guys an announcement this morning on our Canvas page. So I'm going to go ahead and pull that up. Here. Okay, so on the page here, I put a practice math worksheet. So this worksheet is going to be set up just like your test will be. Here, I'll open it up real quick to show you. So everyone mute yourself real quick because I'm getting feedback from someone. Okay, so on the practice math, again, this will be just like what your math test will be like. So you'll have about three questions that are going to have these like medication labels with them, and they're real simple.
We can't see it.
All right, hold on a second.
I'm sorry.
All right, just give me a second. All right, you good now? All right, so
Yes.
again, this is just like what your test will be like. You'll have three medication label type problems in the beginning. They're real simple. You basically just have to look at, hey, what's the concentration of the med on the label, and then look at what it's asking you in the problem. Okay, like this one, hey, you have 25 milligrams per 5 milliliters, and it says you need to administer 14 milligrams. So it's going to ask you how many milliliters are you going to get. So real simple. So that's those three. Then we're going to have a few that are just conversion type problems. So, you know, pounds to kilograms, kilograms to pounds, milligrams to grams, grams to milligrams, teaspoons, tablespoons, and ounces. So make sure you know those. Then we are going to have some milliliters per hour questions. Or actually drops per minute this first. So here's a drops per minute question, here's a drops per minute question, and then we'll do the milliliters an hour ones. So there's like 3 of those, I believe, which we're going to go over those this morning. And then the rest of the test will just be like basic, you know, stuff that you've had before, right? So basic problems, and then like these two, I think, have different, where you have to like convert, you know, so this is 400 micrograms, and what you have is milligrams, so you have to convert, you know. So that's all it is. So that's what you can expect for your math test. So you guys can do that on your own. I gave you a answer key for that, so you can check yourself. If you have trouble and you need to go over something with me, just, you know, get a hold of me so we can do it together, okay? So the other stuff that I wanted to just pull up this morning, let me get it up here real quick. Let's do this one first. Okay, so this one is milliliters per hour questions. So let's go ahead and do these together. So I don't know if you guys did this last term or not. Regardless, if you did or not, this is what we're going over today. And this is what will be on, you know, your math test that you'll be doing. And then our first test that we do, our test 1, you'll have a couple of problems like this. Okay, so with milliliters an hour questions, typically they're going to say, hey, you have an order for this amount of IV fluid to infuse over so many hours. What is your hourly rate? So what you do is you take the volume, like in this first problem here, we would take 300 milliliters, and we would divide it by 6, and that's going to give you how many milliliters per hour this would be. So basic, just dividing, that's all it is. Super easy, right? So I don't know if you guys have your calculators with you this morning, if you want to do that real quick. What do you get when you divide 300
It's
by
50.
6? 50. Okay. So then
It's
the next
50.
one, yes. So the next one, this says 2 liters of D5W and half normal saline is to infuse over 48 hours. So you're going to take 2,000 and divide it by 48. So what would you get when you do that?
Well, first, do we have to convert liters into milliliters?
42.
42 is the correct answer. You're right. So you get like 41.66 whatever, but you know, obviously we're going to convert to a whole number here. So no, you don't have to convert anything so far. Only in this third one here would you have to convert anything. So in the third one, let's look at that for a second. So 100 milliliters of ceftriaxone to infuse over 30 minutes. So this is in minutes, that's what our problem is. So we need it to be in hours, because remember, we're trying to get to milliliters per hour. So you need to convert 30 minutes into hours. So how do you do that?
When you times it by 60?
Okay. Here, let me show you on the whiteboard real fast. See if I can draw on here so you can see what I'm talking about. So because you're in minutes, you have to change it to hours. So you're right, you would multiply it. But just so you can kind of see what I'm talking about. Geez, I can't write with this very good. here's our 30 minutes. And we know that there's 60 minutes in 1 hour, right? I'm used to doing everything in a ratio proportion because it makes more sense to me. So this is kind of what you would do. So you take 30 times 1, right? 30 times 1, which would be 30. And then you take 30, what you got by multiplying, and divide it by 60. And you get something like 0.5. So back to our number 3 problem that we were just looking at, you would take your volume that it tells you, which is 100, and we're going to divide by 0.5. So what do you get when you do that?
200.
200. So that's the only thing that might like trip anyone up on these type of problems. You just have to make sure that you are in the right, kind of what it's asking for. If it's asking for milliliters an hour, you need to be in hours. You have to make sure you're in the right units. All right, so that's kind of what those are like. I don't think there's any other ones that are like too horribly hard. If you want to take a minute to see if you can do a couple more of these before I move on to the drops per minute. Just see if you can do these two right here. This one with TPN and the one with the 45 minutes down here. Okay, let's take a look at these real quick. So for this one, the TPN one, so we have 1,000, that's our volume. So we're taking that and we're dividing it by 36. So what do you get for that?
28.
28. So real easy. Then
28.
correct. So then when you do this one you have to do a little bit of converting. So when you see anything like this where it says 0.8, how do you figure out how many milliliters that is?
Divide by 1,000. What times by 1,000?
No, times 1,000.
Times by 1,000.
Times by 1,000. So what would this be in milliliters?
8,000.
800.
It's
800.
800. Yeah. So in a way, like almost think of it like a percentage. When you're looking at this is less than 1 liter, right? So it's not going to be more
Right.
than 1,000. So right?
Right. Makes sense.
Okay, and then look at your minutes here. So this needs to be converted to hours. So just like we did with that other one. So what would you get for what this would be in hours?
0.75.
0.75.
Correct. So
Zero
you would
point
have
seven five.
800 divided by 0.75. And then you get some kind of big number. This is the
Yeah.
correct answer right here, which is stupid because you would never have a problem like that usually. But that's how you would do it. You're correct.
Okay, can you work through that one all the way? Because I just wanted to know how to set that up.
Yeah.
Set
Yeah,
this problem up.
Let me go back to the whiteboard a second. So I can even see this. All right, let's see. There we go. Okay, so for this one, if you had your 0.8, that's a L for liter, sorry, it's hard to write with this. This is my equal sign. All right, you know 1 liter equals 1,000 milliliters, right? So basically you would take your 0.8 times 1,000 and divide it by 1, right? You would get your 800. So that's going to go on top. That's going to be our volume. Then with our time, it said we had 45 minutes, so we're going to put 45, and we're going to put our 60 minutes over here over 1 hour. And then we are going to get, work it out real fast, 0.75. So we're going to put our 0.75 right here.
Okay, Miss Silk, so you got the 0.75 after you divided the 45 or 60 divided by 45. Is that what you did?
So when I set stuff up this way, this is what you do. So you take your 45 times your 1. The reason I'm not taking this times anything is because I'm crossing here, right? You're cross multiplying.
Right, I understand that.
So 45 times 1 is 45.
Right.
And you take your 45 and divide that by 60 because that's the only thing that's left to do anything with.
I was just trying to figure out which number was divided by which.
Yeah.
To make sure I'm writing it down right.
Yeah, if I had an actual pencil and paper, it'd be way easier. This is really hard for me to write like this. But yeah, so that's all you do. Does everyone...
You put the number up under the 800 and then that's the answer.
Yeah, so you're going to do 800 divided by 0.75 and it gives you some kind of big crazy number, 1,066 point something.
Okay.
So, yeah.
Thank you.
Does everyone else feel somewhat okay with those?
Yes.
Those aren't too bad. I think it's just basic dividing for the most part. All right, so that's milliliters per hour questions. So let me pull up the drops per minute ones. Did you guys do any of this last term at all?
No.
Okay. Okay, here's your drops per minute questions. So what I want you to write down, actually, let me get on the whiteboard a second so I can write this formula for you, and then I'll come back to that. All right, so the formula is going to be volume times the drop factor and then you're going to divide by your time in minutes. So if you just remember that formula every time you do any of these type of problems, you'll be just fine. So volume times the drop factor divided by your time in minutes. Everyone got that written down?
Yep.
Okay. I'm going to stop sharing that a second, go back to the other thing. Here we go. Okay, so for these problems, like this first one says, the doctor's order says infuse 1,500 milliliters of lactated ringers over 12 hours, and your drip factor is 15 drops per milliliter. So, according to our formula, we would take our volume, which would be this 1,500. We would multiply it by our drop factor, which is 15. So let's do that on our calculators here. 1,500 times 15. And then we're going to take what we get and divide it by our time in minutes. So a lot of times when you see these problems, it'll be in hours. So that's the only thing you'll have to convert would be the time. So what would 12 hours be in minutes?
720.
720.
720?
Yeah.
Okay. So what would we get for our final answer?
31.
Correct. So it's something on your calculator. I think it's going to say something like 31.25 or something, but you know, this is wanting a whole number. So
I have a question with this because it gives you two options. It gives you 31 and 32. Is there a round up, round down rule?
Yeah, I'll be specific on the test about that. So this is just practice, so don't even worry about rounding right now.
But this would be 31 though, technically, because it's 0.2.
Correct. Correct.
Okay, so
when you're looking at rounding, you always look at the number right next to your whole number, right? So because it was 31.25, we look at that 2, and anything less than 5, you're going to round down. Anything greater than 5, you would round up for a whole number.
okay, so the volume is the amount that you're giving.
Yes. So
the
again,
1,500.
Yes.
Times the 15.
Correct.
Okay, thank you.
And it's divided by that time in hours.
By the minute.
Excuse me, minutes, yes.
Okay, thank you.
So let's look at the next one here. So 300 would be our volume. So 300 times 20 divided by 40. So look, we don't even have to convert anything. It's already in minutes.
So for this one, do we just not worry about the 500 mg?
Yeah, you don't, that has nothing to do with anything. Because
Okay.
again, remember your formula. Your formula says that volume is what you need. You don't need to worry about milligrams. It has nothing to do with anything.
Okay.
So it would be 150.
Correct. Here, we'll do just a couple more just to make sure you're okay, and then we'll get off of here. Okay, so let's do number 3 and 4. So look at this one. This says the doctor's order says 2 250 milliliters packed red blood cells to infuse over 4 hours, your drip factor is 15 drops per milliliter. So that means you actually have 500 milliliters because it says there's 2 of these packed red blood cells, right? So 250 plus 250. So your volume is going to be 500 times 15 divided by your time in minutes. So figure out what 4 hours is in minutes.
240.
240, right? So again, 500 times 15 divided by 240.
$31.
Yeah, 31.
Yeah, it's 31. So really, you know, if you know that formula, you just cannot go wrong. So just kind of keep that in your memory, what you need for these problems. All right, look at number 4. So this says 2 liters of D5.5 normal saline with 50 milliequivalents of potassium to infuse over 48 hours. Drip factor is 15. Again, don't let this confuse you because you don't need that. So 2 liters is going to be 2,000 milliliters, right? So 2,000 milliliters would be our volume. We're going to multiply that by 15. And then we're going to figure out what 48 hours is in minutes and divide it by that.
Could it be 10?
It is 10.
Okay.
Yeah, so see, these really aren't that bad. So again, I can't stress this enough. Make sure you understand those formulas and how to set it up. Because if you set it up right, you're going to get it right every time.
So the next one will be 400 times 10 divided by whatever the 3 hours is, 3 times 60.
Correct.
Okay.
All right, if you want, I can give you correct answers for the rest of them real quick, and then you could figure them out later to see if you're correct or not. Do you want me to just read off correct answers?
Yeah, you can.
Yes.
Okay, so for this page we're on now, the drops per minute. So again, you know, she was just talking about number 5, you know, where it talks about the normal saline to infuse over 3 hours. That one is 22 drops per minute. Number 6 is 42 drops per minute. Number 7 is 50 drops per minute. Number 8 is 18 drops per minute.
Every time you say the answer, the computer goes off.
I didn't hear a thing you just said. You were breaking up. What was that?
Yeah, I think the computer is breaking up when you're saying the answers.
She said we cannot see your screen because it's blocked.
It doesn't matter. You don't need to see my screen. I'm just reading off the rest of the answers to you guys for this.
No, I didn't say that. I said that I couldn't hear what you said.
You couldn't hear what I said?
You couldn't hear what you said.
Okay. I don't know why we're having an issue
You could
with
just
hearing each other. It's okay. If you didn't hear me, I can just send these to you later. It's
Yeah,
fine.
that would be fine.
Don't even worry about it.
Yeah, don't.
Okay. So regardless, I will send answers to this and answers to the other one that we did later on to you guys, okay?
Thank you.
All right, so that's our math for today. So milliliters per hour questions and drops per minute questions. So that's all we were going to do. Okay. All right, so we need to finish up some of our surgery stuff now. So we are going to get into the intraoperative stuff next. So let me see if I can pull that up. fix this. There we go. All right. So in this chapter, remember with intraoperative, we said the intraoperative period was from when you step into the operating room until you're done with the operation and you go to the recovery room. So it's that whole time you're in the operating room. So this can be very scary. You know, I don't know. I think we talked about this the other day. A few people said that they'd had surgery before. Not everyone has, but it is scary when you go to the operating room. So there's all kinds of people that are in there, and people kind of collaborate together to make sure they take good care of that person in there. So we want to get high quality outcomes for the person who is having surgery. So you have people like, there could be a surgeon in there, there could be an anesthesiologist, a few different nurses, some support staff, there could be residents and medical students in there, like observing the surgery. There's like a ton of people that can be in there. So it's very like an anxiety provoking thing for people to go to the operating room. All right, we need to talk about the different roles of what everyone does in the surgical team. Obviously, we know what the surgeon does, right? So the surgeon is going to take care of whatever your problem is. The anesthesiologist is going to be the one that puts you under for the surgery. So 9 times out of 10, most surgeries, you're going to have general anesthesia where you get put under. That's most surgeries, not all of them. Some of them you don't need to be put under completely for the surgery that you have done. But anyway, whatever anesthesia they give you, this person would be responsible for giving it to you. So there are a couple of different types of anesthesia. There is a type that you can get through the IV, where it's like an IV push kind of a medicine where it works really quickly. And then there's another kind where you can get it through like a mask where you inhale it. So they would be responsible for watching you as they're giving you all of this stuff. So they keep control of your vital signs and watch really closely throughout the whole surgery how you're doing. Then we have the circulating nurse. The circulating nurse, this person is kind of in charge of what happens in the operating room in a way. He or she is not sterile in the operating room. You know how most people are sterile when they go in there? She is not. He or she. I keep saying she, sorry about that. So this person is going to be the one that documents everything that happens in the OR. So they document the time the surgery started, if there's any adverse events that happen during the surgery, anything along those lines. So this person also protects the patient's safety during the surgery. I keep hearing myself. I don't know if everyone's muted or not. Can you guys please make sure you're muted so I don't keep hearing all kinds of other stuff? Thank you. Okay, so again, with the circulating nurse, he or she documents everything that happens in the OR. You protect patient safety by monitoring activities of the surgical team. This means that if you see someone break sterile technique, you call them out on it. So the circulating nurse would say, hey, Dr. So-and-so, I noticed that you touched that table over there. You need to go re-scrub. And we need to, put new stuff on the table now. So they are responsible for that because they're looking out for the best interest of that patient. Other things that they do, they check the OR conditions. So like this person would be responsible for going into the OR before everyone else does to make sure like that everything works, like the lighting is just like it's supposed to be, all the equipment is there that they need, all that type of stuff. This person is also going to verify consent. So remember when we talked about consent the other day, we said that, you know, when someone gets consent, it's the surgeon's responsibility to get consent from them, not ours. But we would be the person, you know, the nurse would be the person that would be the one who would verify and be like the witness that they signed their consent. But in order for this person to be able to go through with surgery, that physician attestation portion of the consent needs to be signed. So remember we said what that was the physician would sign to say, yes, I have talked to the patient about the risks and benefits of this surgery. So if that wasn't done, then they would stop right then and there until it was done. They would not go any further with the surgery. Let's see what else. Oh, other things, you know how we talked about the timeout the other day? This person would also do that before the surgery started. So you would verify that you have the correct patient. You know, if you were working on a certain limb, you would verify you have the correct limb, all of those things. So the timeout would be done beforehand as well, and the circulating nurse would be the one to do that. The circulating nurse also kind of helps pad up the patient. So you know how in surgery, sometimes you're laying there for hours on end during the surgery. So, you know, the patient's at risk for pressure ulcers and stuff. So they have all of these different wedges and things that they can put underneath the patient to, you know, put them in a certain position. So this person is responsible for, you know, doing that. So those are some of the things that the circulating nurse does. Then we have the scrub nurse. So the scrub nurse is actually sterile. So remember, the circulating nurse is not, but the scrub nurse is. So they are going to do that surgical hand scrub just like the surgeons and everyone else who goes into the OR. They are responsible for setting up the sterile tables, preparing sutures, and any kind of special equipment that they might need. This person is going to assist the surgeon during the procedure by anticipating what instruments and supplies that they need. So like after you, I don't know, does anyone in here work in surgery right now? No? So I know I had a few people a couple of terms ago that did work in surgery. So anyway, if you work in surgery, you have like a really long orientation period. So something like 6 months or something, 6-7 months. So you work with a certain group of surgeons all the time. And you go in on all of their surgeries so that you can learn what they like and their preferences. So you kind of anticipate what they want next because the surgery is done the same way all of the time, you know? So I remember years ago, I got to go in on an open heart surgery and I got to observe that. And I had a surgeon who was pretty ridiculous in that surgery. And I don't want to say every surgeon is like that, but quite a few of them are. They're just very, I don't know how to explain it, very particular about what they like and what they want. And if you don't do it that way, they're going to tell you about it. So this poor girl was just like learning her job, and she must have handed him the wrong thing, and he flipped out. So he yelled at her, threw the instrument that she handed him across the room. He ordered her to get out of the OR. Like, it was a huge ordeal. It was ridiculous. So yeah, they have kind of a stressful job in surgery. Other things, so with the scrub nurse, not only are they doing that, like handing things to the surgeon during the surgery, but at the end, when the incision is closed, the scrub nurse and circulating nurse both together count needles, sponges, and instruments to make sure they're all accounted for. If there was any kind of tissue specimens or anything like that that they got during the surgery, this person would label them and send them to the lab. So that's kind of what the scrub nurse does. Then there is a registered nurse first assist. So I don't know if you've ever even heard of that, but what this is it's a person who is an RN, just like a regular RN, but they have a little bit more schooling in surgery type things. So, you know, compared to a regular RN, like they go to school for a little bit longer for this. So what happens is they will insert tubes, they can administer needles, close wounds, cut sutures, harvest surgical grafts, apply wound dressings. So they do a little bit more than just the basic scrub nurse would do. So like for instance, you know, with open heart surgery, you know how you have an incision on your chest, you know, to open up your chest to get to the heart. Well, you also have an incision on your leg where they would take a vein out to harvest and put up into your heart, you know, to bypass, you know, the blocked vessels. So the surgical first assist might be the one that actually harvests that vein out of that leg. So they would actually be able to do that.
Miss
So-
Silk, this is actually the kind of nursing I want to do. I want to get my RNFA first assist certification.
Oh, that'd be awesome. Yeah, I mean, you can do quite a bit with it, and it's I know a few people who do that, and they love it. So that's great.
I just think it's really interesting, so I'm looking forward to it.
Yeah, that'd be awesome. Yeah, I hope it works out for you. I think they definitely need good people in surgery for sure.
Thank you.
Okay, the next thing here, we want to talk a little bit about the surgical environment. So typically, wherever your facility is, usually your OR is going to be kind of in a central place. So it's usually going to be close to, you know, maybe radiology, the lab, the ICU, that type of stuff, so that you don't have to go very far to get to places. Sometimes maybe even a pharmacy is really close by. It's like, you know, in a central area. There is a special air filtration system in the OR to help filter out things like particles, dust, and pollutants, because you don't want any of that floating around in your OR. I put on here about fire. Fire is a really big risk in the OR because of three things. So you have a source of fuel in the OR, you have an oxygen source, and you have a mechanism to ignite fire. So there are fires in the OR. Every so often you'll hear that someone had a fire in there. So all surgical personnel have to be familiar with what they need to do, you know, for fire safety and all of that kind of stuff, what the emergency response plan would be. Okay, another thing that we need to talk about is the 3 zones in the surgical area. So when you go down to the OR, they have 3 zones there. So there's an unrestricted zone, a semi-restricted zone, and a restricted zone. So the unrestricted zone would be where street clothes are allowed. So like you could actually have your own clothes on, and maybe like the locker room or something would be there so that you could go change into your scrubs before you start on your shift or something. Traffic is not limited here. This area is separated by doors from the main hospital corridor. The area allows for communication with department and hospital personnel. And other things that might be located in this unrestricted area would be maybe the supervisor's office or the surgical scheduling office as well. So, you know, locker room, operating room, supervisor's office, surgical scheduling office. So in the semi-restricted zone, this is where you have to be in scrubs and you have to have a cap on your head. So traffic is not allowed to everyone in this area. So you have to be in scrub attire and your hair has to be under a cap to enter into this area. So usually this area includes the support areas of the surgical suite. So some examples of things like that would be corridors that are outside of the operating room. They have clean cores and substerile rooms designated by the facility that might be there, storage areas for clean and sterile supplies, that type of stuff would be in that semi-restricted zone. So when we talk about the restricted zone, now you have to have everything on. So the scrubs, the shoe covers, the caps, masks, the whole 9 yards. So you have to wear all of that because, you know, you're like right where the OR is basically. So areas where unwrapped sterile supplies are provided to carry out procedures are carried out in these areas. So like you might have a procedure room, an operating room, scrub area, any of that might be in the restricted zone. So like for testing purposes, like we may ask you about one of these zones and what would be required for you to have on, or what might be located in that area. So that's kind of stuff you need to know. Okay, so masks are worn at all times in the restricted area of the OR. They should fit tightly over the nose and the mouth completely. They should be changed between patients and should not be worn outside the surgical department. Headgear should completely cover the hair. You don't want any hair sticking out anywhere. Shoes should have designated use for OR only. This means that your shoes that you wear to the hospital, you would change. So, because you've been outside in those, right? So those you would put in your locker, and you would have specific shoes that you only keep at the hospital and you put on to go to the OR. Other things, your fingernails should be really short, and you know, you don't have any artificial nails or anything when you work in the surgery department. All right, surgical asepsis. So this is something that you guys should have learned in fundamentals. So this is something that you really need to make sure you review to make sure you're really good with this. So basically, when we talk surgical asepsis, this means that anything that comes in contact with a surgical wound or is used within the sterile field must be sterile. Sterile surfaces or articles may touch other sterile surfaces or articles and keep sterile because they're both sterile, right? But if you contact something that's not sterile, then that makes you contaminated. So items are dispensed to a sterile field by methods that preserve sterility of the items. So like if I have a table that I just set up, you know, with all of these instruments on it, if I have to add something to that, like say I have to open up a dressing, I open up the dressing just with the very edges of it, and then I turn it upside down and drop it on there, and that remains sterile now. Let's see, sterile supplies are delivered to the sterile field or handed to the scrub person in such a way that it remains, you know, that sterility remains intact. And then just remember, movement around a sterile field must not cause contamination of the field. At least 1 foot distance from the sterile field must be maintained to prevent inadvertent contamination. So I remember when I went to observe a surgery, it was very kind of nerve-wracking because they make you stand in a certain area, but you're kind of close to things, and you feel like you just want to stand like this so you know, you don't inadvertently touch something and screw something up. So it's kind of neat though. If you guys ever get a chance to do that, it would be cool. Okay, so there are some health hazards associated with surgery. So, you know, unfortunately, pretty much anywhere you work at, you can have faulty equipment. So that can happen in the OR too. So that's something that could happen. You could be exposed to toxic substances. That can always happen regardless of where you work at. Needle stick injuries. Again, that could happen wherever you're at, not just in the OR. Lasers, that would be something more specific to the OR, I think. So occasionally you'll have a surgery that they'll use a laser and you get smoke that develops from this laser, and exposure to your eyes and skin can cause problems. So anytime you use a laser, you have to have special eye gear, and like you have to have your skin protected as well. And then, you know, we talked about in the OR, they have that special air filtration system. So when the smoke starts to happen from the laser, that air filtration system like sucks it up to get it out of there. So it's not just all over the place. Exposure to blood and body fluids, that's always, you know, a big deal too. Okay, so now we start getting into some anesthesia and sedation stuff. So we're going to talk about the different types of anesthesia and some just general things to know about it. And then after we get through that, we start talking about some potential complications that you can have in the OR, and then some like nursing intervention type things that you would do for those. And then we end a little bit with different ways to position people in the OR. Okay, so this first part, we're talking about general anesthesia. So when you have general anesthesia, this means that you are in a state of narcosis. So everything is very depressed. So you are super relaxed. You don't have complaints of pain or anything because you're so relaxed, and you actually have a loss of reflexes. So you are not able to arouse this person. So no matter how much you like shake them or shout at them, they're not going to arouse. And they don't even arouse to painful stimuli. So if you started to like pinch them or do anything like sternal rub or anything, they wouldn't arouse. So they lose the ability to maintain ventilatory function and require assistance with maintaining a patent airway. So this means they have to be on a ventilator. So everyone who has general anesthesia is put on a ventilator because they can't breathe on their own. They lose all of their reflexes. So if you ever have to have surgery and they tell you you're going to have general anesthesia, you can expect that you will be intubated and be on a ventilator for a certain period of time. So the next part of this talks about stages. So when you induce someone into this state of narcosis, there's different stages. So the first stage is where they first start giving you the anesthesia. So you might feel a little dizzy. You may feel like you're kind of outside of your body, like you're looking at yourself doing stupid things, but you can't have any control over it. So this is like that first stage where you just feel kind of funny. Noises are exaggerated. You may have a sense of the inability to move your extremities. Like you can still move them, but it feels like they may weigh a ton, you know? And then the second stage is the excitement stage. So during this, people do some funny things. Sometimes they'll start singing or talking or laughing or crying. They may have uncontrollable movements and need to be restrained. So typically they do restrain you in the OR because you don't want someone moving around and causing all kinds of trouble during your surgery. So they do kind of make sure that you're kind of strapped down so that you can't do all of that. Stage 3 is what we are going for. So as we are trying to get this person under and in a really good state of narcosis for the surgery, that's what we want. We want stage 3. So usually to reach this, you give them a combination of the vapor to inhale in, and then you support it by giving IV stuff as well. So they get both types of anesthesia. And that kind of keeps them at an even keel. So if someone reaches stage 4, that's a problem. So this is called medullary depression. So when you reach this stage, you've had too much anesthesia. And now your respirations start to get shallow, your pulse gets weak and thready. Sometimes you get cyanosis. Your pupils look really wide and they won't constrict. So if you don't intervene and do something about this quickly, this person can die. So you don't want to get to that stage. So basically, you know, the anesthesiologist knows what they gave, you know, for the medications, for the anesthesia. So if they did go to the stage, they usually have like antagonist type meds that they can give to counteract what they gave to get them to come out of that. Oops, sorry, I'm on the wrong slide here. Here we go. Okay, so again, you know, we talked about how you can get this type of anesthesia through, you know, a mask or through the IV. So relatively large amounts of anesthesia must be administered during induction and early maintenance phases because the anesthetic agent is recirculated and deposited in your body tissues. As these sites become saturated, smaller amounts of anesthetic are needed because equilibrium or near equilibrium has been achieved between the brain, blood, and other tissues. So typically, intravenous anesthesia is used for induction of anesthesia, and inhalation anesthesia is used to progress the client from stage 2 to stage 3. So that's kind of how they do that.
Can you repeat that again?
Yeah. So all I said was the IV type of anesthesia is used
Right.
for induction, so to get them under. And then the inhalation anesthesia is used to progress them from stage 2 to stage 3.
Okay. Thank you.
Sure. All right, so now we're going to move on to talk about regional anesthesia. So this type of anesthesia is different. It's not like general. So under this category, you would have epidurals, you would have spinals, anything like that's a block, you know, that would be considered a regional anesthesia. For example, again, I always bring in my family in some of these conversations. So my daughter had that wrist surgery. So she had a cyst on her wrist that they removed, and it was kind of a long surgery. It was crazy. But anyway, for that surgery, they actually did a block on her. So they injected her like up around her shoulder somewhere and blocked her feeling to her whole arm. And so that lasted for over 24 hours. So she felt like her arm was dead. And like after the surgery, she had to have a sling and everything for a little bit until her feelings started to come back. So that's regional anesthesia. So what happens then is they take this anesthesia and they inject it into a certain place, and wherever they inject it from there down is where you don't have sensation. That's basically what it is. So like when we talk epidurals, this is a local anesthetic that's injected into the epidural space that surrounds the dura mater of the spinal cord. So they inject it into your spine, basically. The medication diffuses across the layers of the spinal cord to provide anesthesia and pain relief. So I had an epidural when I had my kids, and it worked great. I loved it. I know some people don't have a good experience with it, but you know, it was fine. I liked it. And then with spinals, again, the same type of thing. It's really done the same way, but it's just different where they put it. So with a spinal, the local anesthetic is injected into the subarachnoid space at your lumbar level between L4 and L5. So it produces anesthesia of your lower extremities, your perineum, and your lower abdomen. So sometimes people will get a headache from any of this stuff. So like epidural or spinal, you can get a headache. So 3 things can affect this happening. So the size of the spinal needle, the leakage of fluid from the subarachnoid space around the puncture site, and the patient's hydration status. So typically if someone gets this spinal headache, you want to maintain a quiet environment, keep the patient laying flat, and keep them well hydrated. Now, I have a girl in one of my other classes currently who just had a baby, had an epidural, and ended up with a spinal headache. So they did like just maintenance type things like this at first, you know, made her lay flat and kept her hydrated and stuff, but it didn't work. So what else do you think they do to help fix this? What would they do?
A patch.
Yeah, have you had that before?
My
Or do
mom
you-
has.
Okay. Do you understand what they do with that? I don't know if you can explain it to people.
That's a little bit above me.
Okay, that's okay. So basically, what's happening here is you have this leakage of spinal fluid that's causing this headache. So they actually go in and they inject into that space something that'll like be like a patch to plug up that leak. So that's how they fix that, basically. That's what this girl in my other class had to do too. And once they did that, she was way better. So just
So it
be
would just be use of a patch.
it's called a blood patch. So they
Okay.
actually, yeah. So they inject blood into that space. And it kind of like stops the leak. Okay. Let me see if I forgot anything on this slide here. Oh, so during regional anesthesia, you can be awake during this. So like, you know, even though my daughter, she had general anesthesia plus the block, like not everyone has to have that. Like some people don't do well being put under for anesthesia and, you know, for one reason or another. So a lot of times they use blocks anymore and you can actually be awake during the whole thing. So it just depends on the surgery and the severity of whatever you're having done. Spinal anesthesia can be used with almost any type of major procedure performed below the level of the diaphragm. So I think anymore, they're trying to do a lot more of these types of things to help people because, you know, with the opioid crisis and everything, so many people are having issues with, you know, addiction problems. So they figure if they do this type of anesthesia, then maybe they will have a better time and not, you know, have problems with the addiction afterwards. Okay, moderate sedation. So this is something that you will probably see done a lot in your nursing career. So the other name for this is conscious sedation. And what happens with this is you give someone some medication to kind of put them under in a way. But the difference between this and general anesthesia is when you give them this medication to put them under, you can still arouse them. And they don't necessarily lose their ability to breathe on their own and that type of thing like you would with general anesthesia. So, like some examples of ways that you would use this. So if I had to go get an endoscopy, like a colonoscopy or something like that, they do moderate sedation for that. So they give you medicine, typically through your IV to make you sleepy. Sometimes people actually stay awake for it. It just varies, you know. But anyway, if they do moderate sedation, they're going to give you medicine. It's going to make you go to sleep. And then when you get up, the nice thing about this medicine that they give you is it works really quickly. So it doesn't stay in your system forever. So basically when you wake up, you almost have like a little bit of amnesia, like you're like, oh, did they even do the surgery yet? You know, you'll say crazy stuff like that, but you recover really quickly from it. So that's the nice thing about it. So during this, you know, you as the nurse would have to monitor their vital signs. You would have to make sure they have oxygen on, whether they normally wear it or not. During this procedure, you would make sure they had it on. You would have suctioning equipment available just in case they start to have issues with their airway. So other things that they would do moderate sedation for. So say you work in the ER and someone has to get a chest tube placed. They would do moderate sedation for that. If someone came in and they dislocated something like their shoulder or something and they had to put it back into place, they might do moderate sedation for that. There's quite a few things if you really think about it. They do it for a lot of stuff. So on the floor that I used to work on, we used to do cardioversions a lot. So when someone would be in an irregular heart rhythm, we would shock them out of it. So you would do conscious sedation for that even. So I've seen it done a lot. So basically you take their vitals kind of often, like every minute or two, you're taking their vitals to make sure they're staying stable. And then during the procedure, you're going to watch how they're breathing. So if they start to breathe a little funny, then you may have to like hold their jaw a certain way to make sure their airway is okay and it's being maintained. So when someone gets too relaxed, they kind of like cut off their airway in a way. So if you adjust their jaw a certain way, it kind of keeps it open so they can still breathe. So you may be holding onto their jaw during the procedure. All right, so on this, let me see if I missed anything. Okay, so you will get a decreased level of consciousness, but you'll be able to maintain your airway. Most of the time you can maintain it. Sometimes people get too relaxed, but most of the time you can maintain it. You retain protective reflexes and you can respond to verbal and physical stimuli. So during conscious sedation, the patient's never to be left alone. This is super important and is closely monitored. Vital signs, pulse ox, level of consciousness, all are monitored. The patient must be on a heart monitor and have a trained physician, anesthesiologist, or trained nurse present while this is going on. So let's talk just a second about something that we all have heard about. So Michael Jackson. So remember when Michael Jackson died and they talked about the medication that he received? Do you guys remember hearing about that?
Yes.
Yes.
So the medication that he received is a typical medication that you would do moderate sedation with. So when all of that started to come out about what actually happened with him, you heard that that doctor didn't stay with him during that. He left him alone, which is crazy. So all kinds of things could have went wrong, and they did, you know? So
I'm sorry, Mrs. Silk. I lost internet connection, so I just came back. I know we're on the same slide, but are we talking about what are we talking about?
it's okay. I'm talking about Michael Jackson, actually.
Okay, I figured that's who it was, but
Yeah.
okay.
So anyway, the medication that he got, you would never give it to put someone to sleep, you know, because they were having trouble sleeping. That's not why you would ever give this med. So that was just totally wrong what they were doing. But just know that this medication, you know, things can go wrong. You just cannot leave someone by themselves. So
Is the name of it propofol?
Yes.
Okay.
Yes. So anyway, if you ever get to see it, it looks like milk. It's white. And you really don't even have to give a whole lot to get someone to go under. It happens really quickly. And then if you're taking a little bit long with whatever procedure you're doing, you may have to give some more. But they recover really quickly from it. They'll wake up really fast. So, and obviously, like for Michael Jackson, he must have had a ton of it to not be able to wake up. So. Okay, so we'll move on to local anesthesia. So local anesthesia is something that you would get, like say you have to go get, you know, stitches or something for something, you would get local anesthesia for that. So you inject this into the tissue or, you know, at the incision site or whatever, and it kind of like numbs up that area. So for all of us, if you've ever been to the dentist and had to get some dental work done, local anesthesia is what they give you. So they inject your mouth, you know, with Novocaine, and that just like numbs up the area so they can do whatever they need to do. So advantages for this is it's ideal for short, minor surgical procedures. You post-op recovery is really brief. You don't have to worry about that for too long. A lot of times with general and some of those other things, you have some undesirable effects from it. With this, you really don't. So you really don't need a whole lot of equipment, and it's really cheap, so it's not bad. A lot of times, I think it said this in the book, that sometimes they'll administer this with epinephrine. So typically it's going to be like, lidocaine or something that you're going to give someone. But a lot of times they'll give it with epinephrine because epinephrine constricts your blood vessels, and it prevents rapid absorption of the anesthetic agent and prolongs the local action and prevents seizures. And usually whenever you get, lidocaine, the physician will always say, oh, it's going to just be a little stick and a burn, a stick and a burn. Because the stick part will be from the needle going in, and the burn will be from, when they actually push it in. So that's kind of local anesthesia, so that's not too bad.
And you said it's given with epinephrine because it lowers it decreased the effect of it?
So they give it with epinephrine because it constricts the blood vessels.
Okay.
So when it constricts the blood vessels, it prevents rapid reabsorption of that agent, and it prolongs its action. So it works for longer if you give it with epinephrine.
Okay. It prevents the rapid. Okay. I got it. Thank you.
Okay. All right, so now we're on to the complication portion of this. So anesthesia awareness is something that is just scary to think that it could even happen, but it does. What it is, it's unintended intraoperative awareness. So the patient becomes cognizant of surgical interventions while under general anesthesia, and then they recall the incident. So if you ever saw this happen, you would see an increase in blood pressure, an increase in heart rate, and you would also start to see the patient move. So pre-medication and amnesiac agents and avoidance of muscle paralytics are usually what they do to try to prevent this from happening. So I'm sure you guys have all seen this on TV shows before, where someone will go to surgery and they'll start waking up during the surgery or something. I know they've done this on Grey's Anatomy before, where this lady was getting some kind of gastrointestinal surgery, and they had her all opened up, and she started to wake up, and she remembered the whole thing, and it was just horrible. So this doesn't happen like a lot, but there is a small percentage of people out there that do have this happen. So again, when you're in OR, people are like draped all over, because everything is like sterile and everything, and you don't really see the patient really good because they're so draped, right? And so the way that you can figure this out, that this is happening, is you're going to see movement, like you might see their hands or their feet move or something, and then you're going to see it in their vital signs. So you would definitely try to give different types of anesthesia so that this doesn't happen anymore.
There was a movie like that too. I forget, it was a while back, but a guy was on the table and he ended up getting up, but they couldn't tell that he was up.
Yeah, it's crazy. I can't even imagine how horrible that would be.
Yeah.
Okay, nausea and vomiting is another complication. So you wouldn't think that this would be a worry while you're in the OR, but it is. So the anesthesiologist will actually give antiemetics pre-op, intra-op, and post-op to help with this. So they always talk to you before you go in for the surgery, and they'll ask you if you've had any issues with anything in the past. And so if you do say that you've had issues with this, they will, pay special attention to it then. And obviously you wouldn't want someone to start vomiting in the OR when they are intubated and everything, because then they're going to aspirate, so it's a big deal. So you have to watch for that. Anaphylaxis is another thing. So anytime the patient comes into contact with a foreign substance, there's a potential for an anaphylactic reaction. Even surgical glue can sometimes do this. Surgical nurses need to monitor for signs like shortness of breath, wheezing, hives, swelling, any of that kind of stuff. So, if you think about it, we use foreign substances all the time, right? So, like staples or sutures would be a foreign substance. Anything like that. Like if you're putting in a mechanical valve or something, that's a foreign thing in the body. So you could always have some kind of crazy reaction. So you have to watch out for that. Hypoxia is another thing here. So we are going to really keep a close eye on their pulse ox during the procedure because brain damage from hypoxia can occur in minutes. So you have to really monitor well to make sure that they're oxygenating good. Hypothermia is another thing that is a big deal in OR. So we have to keep track of their temperatures while they're in the OR. They have multiple ways that they can do this. I know I've seen a Foley catheter that can actually keep track of your internal temperature as well. So there's multiple ways that they can keep track, but in the OR, it's always colder, and they keep it that way on purpose to prevent, germs and bacteria and things. So, hypothermia is where you can't maintain your own temperature and you're really cold. So who else do you think would be at a real risk for hypothermia other than just a regular patient? Who would be at more
Older
risk?
adult.
Yes. Yes. And why would that be?
They don't have as much skin, less. I can't really say it, but it's not. It's thin. It's thinner than most.
Yeah.
Like the
Adipose
older
tissue.
Yeah. Yeah. So they don't have that subcutaneous fat to help keep them warm. And just like with babies, like I'm teaching a class right now that has to do with that stuff. So if a baby is born premature, they are at risk for that as well. They're at risk for cold stress, right? So it's because they don't have all of that fat on them because they haven't developed because they were born premature, So yeah, hypothermia is a huge deal here. Okay, malignant hyperthermia. Have you guys heard of that before? Anyone heard of that?
Yes.
No.
Okay, so I don't know if maybe Miss Kimes talked about it at all on farm, because there's a medication that you give specifically for this, and maybe she talked about it in there, but maybe not. Okay.
I don't think so.
Okay, no problem. So what this is it's something that happens only when you're in the OR, okay? So it's a rare life-threatening condition that's caused by an anesthesia.
I think she did. I forget what it is, but I think I remember that.
Okay. So what happens is you get a drastic, uncontrollable increase in skeletal muscle oxidative metabolism. So it makes your muscles like tense up. And you also have an increase in your temperature. It causes circulatory collapse, a bunch of things, okay? So this is an inherited autosomal dominant disease. So that means it gets passed down to you from your parents. So people who are at risk for this would be strong, bulky muscle type people. If you have a history of muscle cramps, if you have an unexplained temperature elevation, an unexpected death of a family member during surgery that was accompanied by a febrile response, any of those things would put you more at risk for this. So listen to me closely here. So when this happens, the first thing you are going to see is what?
Elevated temp?
No.
No.
It's going to be tachycardia.
Oh.
So that I want to make sure you guys are clear on that, because even though it's called malignant hyperthermia, that's not the first thing that you see.
Okay.
It's one of the last things that you see. So tachycardia is going to be the first thing. So your heart rate is going to go up high, like over 150. That's one of the early things that you'll see. Then you'll start to see the muscle rigidity. Then you could start to see heart dysrhythmias, like ventricular dysrhythmias. Then your blood pressure is going to start to go down. Then you're going to have oliguria. Do you guys know what oliguria means?
Some of the urine.
So it means your urine output is going to go down drastically.
That was the A one, right?
No, O.
Oh, okay.
Oliguria.
Okay.
Because it was like scanty, right?
What's that?
It is like oleuria. I think our definition was, it was like scanty, something like that. If I'm
So
Oh yeah.
there's a difference between anuria and oliguria.
because
Right.
anuria is no urine, right?
Well, yeah, when we get into adult too, I'll talk about that more. But generally, anuria, it can mean no urine, but it can mean that you make a little bit.
Okay.
So like it could be maybe 80 milliliters or less of urine.
Like it's less than what the normal is supposed to be.
Okay.
Oliguria, it's less than what the normal is going to be as well, but it's more than anuria.
Okay.
Okay.
Anuria is like a certain amount, like less than like 30 milliliters or 50 or something like that.
It's
Right.
less than 80.
80. Okay. I have a question. You said heart dysrhythmias, and then I didn't hear what you said after heart dysrhythmias.
So I also said your blood pressure would go down. And then we talked about that oliguria. And then eventually you could go into cardiac arrest. And then one of the last things you would see would be that high temperature. And get this is crazy. So the high temperature, you're going to see a rise in the temperature that increases 1 to 2 degrees Celsius every 5 minutes. So the core body temperature can exceed 107. Isn't that crazy? So your temperature is going to go up like drastically every 5 minutes, and then it's going to be like super high.
That's crazy.
And is the body temperature, is that what actually killed the patient or no?
Well, it's not just that. It's all the other
all
things
the
too.
symptoms
Yeah.
together.
Yeah.
Okay.
Yeah. So what we would do for this, if you see this when you're in surgery, you're going to stop the surgery right away. You're going to give a medication called IV dantrolene. Do you guys remember that?
Is there another name for that?
Well, let me spell dantrolene. There probably
Okay.
is, but I don't have the other name written down here. So let me spell dantrolene. It's DANTROLENE. So again, we're going to stop the surgery. We're going to give that medicine. That medicine, what it does is it helps with that muscle rigidity. So that's what it's for. We are going to give this person 100% oxygen. And then we're going to do things to try and bring down their temperature. So we could give iced normal saline. We could apply a cooling blanket. We're probably going to insert an indwelling catheter if they don't already have one. We're going to monitor their output really closely. We're going to get blood specimens, ABGs, electrolytes, all kinds of things to send off to see what's going on. So basically, with these symptoms, we're treating the symptoms is what we're doing. So even if, like, say we were doing open heart surgery and this person's chest was wide open, we would stop right then and there, take them to the ICU, just cover up their incision as much as you could, and just treat all of those symptoms to get them through this.
You said that it was passed down by parents. What was the technical term used for that?
It's an autosomal dominant disease.
Okay.
Okay, so the anesthesia that causes this to happen, like you wouldn't know that you had this unless you had to have surgery and had anesthesia. So the anesthesia that causes this is usually inhaled anesthetics like succinylcholine. So I can spell that for you as well. It's SUCCINYLCHOLINE. So, if you figured out that this person had this, then it doesn't mean they can't have surgery anymore. They could still have surgery in the future, but you would stay away from that particular anesthetic agent. And everyone would have to be made aware that this has happened with them before.
So it's not just the inhaled, since we had the IV and the inhaler one. Okay, never mind. My question is stupid because you did explain to me what the IV does and what the inhaler does. So never mind. I got it.
Okay. All right, so that's malignant hyperthermia. So that's kind of a big time complication that you could see in the OR. Okay, so nursing interventions during surgery. I have reducing anxiety here. I know that seems kind of funny because you think the minute someone gets into the surgery room, they're going to be put out, and how would that matter? But for certain surgeries, you actually are awake when you walk into the surgery and you're very nervous, right? So, sometimes you'll have patients who are still awake when they're at the stage. So yeah, you want to reduce their anxiety as much as possible. So, you try to say, hey, I'm going to be there with you throughout the surgery. I'll be monitoring you really closely. I'm not going to leave you. Everything's going to be fine. That type of thing. Reducing latex exposure. So if someone has a latex allergy, that needs to be all over the chart and everywhere, so everyone knows. And so if you know this ahead of time, you can plan for it and make sure that you don't have any latex products anywhere near them. We want to prevent perioperative positioning injuries. So sometimes surgery lasts for a long time, and you can be, just, there in that same position for hours. So you need a nurse that is checking on some of these things constantly, right? So you need to be looking at their skin to see if they're starting to get red in certain areas, and then adding some of those wedges or whatever to try and help prevent some of those positioning problems. You also need to protect the patient from injury. So again, being an advocate, so if you see that someone is breaking sterile technique or anything, you need to say something. And, that goes with number 5 here. But also, so I don't know how to explain it. So in surgery, they have like a grounding pad, which I don't know if you know what the heck I'm talking about, but it's a pad that you would put under the patient's bed in surgery, that if there was like an electrical current of some sort, it helps so that they don't get electrocuted, I guess you could say. So that's kind of another protection type thing that is in place for them. And then just monitoring and managing potential complications is really important. So all of those things we just talked about for complications, those are things we'd be watching for. All right, and then this last thing is just talking about positioning. So there are 3 million different ways that you can position a patient in surgery. And I don't know if did you guys do this very much in funds? Did you talk about the different positions people are in and what they're called?
Just the supine, prone on the side. But as far as
Semi-swaller.
the ones on the bottom, no, I don't believe.
No, not those ones.
Yeah, so I would definitely try to get more familiar with some of these positions, because you never know, you may see this on NCLEX at some point as far as what position is what. Let me see, I think it's in, let me look at something real quick.
How do we know what's A, B?
Hold on.
Okay.
Yeah, so in your fundamentals ATI book, which I don't know if you ever looked at this chapter or not, but there is chapter 14 that's called Ergonomic Principles. When you look in here, they talk about all of these different types of positions: the semi-Fowlers, the Fowlers, the supine, the dorsal recumbent, prone, lateral or side lying, Sims, Trendelenburg, all of these different positions. So that's important to kind of understand that. So basically, this top one here is just supine. We all know that, right? So just laying flat, supine. This one here, this is a Trendelenburg position. So I have my head lower than my feet. So that's a Trendelenburg. The lithotomy position is this. So this is the one where your feet are up in the stirrups. So like, I don't know, maybe you had a surgery where you have to get something removed from your perineal area or something. That's a position you would be in. And then this one here, this is just like a side lying position. So you might be in a position like this if, say, they had to do kidney surgery or something for you. You know, like maybe they had to do a nephrectomy or something. You'd be like this. So definitely try and get familiar with those different types of positions. That's a good thing to know just for future. All right, any questions about the intra-op stuff so far? Okay. All right, so we're going to go ahead and get into the post-op stuff now. Let me see if I can pull that up real fast. All right, so with post-op stuff. Oh, you know what? I forgot to tell you this for the other. So you know how I was telling you about what ATI chapter goes with what? So with the intra-op stuff that we just did, the intra-op stuff in the MedSurg ATI book would be chapter 94. And now with this post-op stuff, the chapter in ATI would be chapter 96. Okay, so remember the post-op period is going to start from when they come out of the OR to you, so it starts when they get in your recovery room and it lasts all the way until their follow-up appointment. So it's kind of a long period of time. So during this time, your care is going to be focused on trying to restore their equilibrium, getting them back to normal as much as possible. You're trying to deal with any kind of complications they might be having, and then try and alleviate their pain as much as you can. So different hospitals are set up a little differently. I know at Children's they have different phases to their recovery room. So I don't know if any of you guys have had your kids there before for surgery, but they have different phases where you have a phase 1, phase 2, phase 3. Whereas other places may not have it like that. They may be slightly different. So I'm just talking about what these different phases are here. So phase 1 would be right when you come out of the OR, you would be in phase 1. So you need a little bit more intensive nursing care at that point because you're not quite coming out of your anesthesia enough yet. So, like, you might be on a heart monitor, you would have like one-on-one nursing care basically. So sometimes people are still ventilated, so you would have to, take them off the ventilator once they get to the recovery room. Um, there's a lot of intensive things that you do in that first phase. So that's phase 1. Phase 2 is when, like, you've been in the recovery room for a little bit, and now you're fully awake, and they're just trying to make sure that your vitals and things get back to normal, so that you're still in there for a little bit longer, but you're better than you were when you first got in there. So they would move you to phase 2. And so if you're in phase 2, you don't need one-on-one nursing care anymore. So you might have a nurse that has 3 or 4 other patients as well. So also on the slide here, it says the patient is prepared for self-care or an extended care facility. So like, you try to get them to the point where they're ready to be discharged, right? So if you're trying to see if they can eat or drink something without throwing up, then you give them that there. You want to see that they can go to the bathroom before they leave. If that's the case, you would do that there, that type of stuff. Phase 3 is where you're pretty much ready to be discharged. So you don't need much care at all, and maybe they're getting your discharge instructions together and stuff. So patients can remain in the recovery room for as long as 4 to 6 hours, depending on the type of surgery they had and any kind of pre-existing conditions or comorbidities. So yeah, they can be in there for quite a while. So when someone gets to the recovery room, usually it's going to be an anesthesiologist and another surgical team member that accompanies them from the OR to the recovery room. So they are the people that you're going to get report from. So if you were the person working in recovery, they would tell you this stuff. So some of the things they're going to tell you is going to be the patient's name, their gender, their age, their allergies. They're going to tell you what surgical procedure they had, the length of time they were in the operating room, any kind of anesthetic agents that they used, and if they had to do any kind of reversal agents. They're also going to tell you estimated blood loss and fluid loss. They're going to give you a last set of vitals and also any problems that they had during the procedure. They are going to tell you about the patient's medical comorbidities, if there are any special considerations for the immediate post-op period. Like, for instance, say maybe I'm a male and I had one of those TURP procedures for my prostate. So if you have a TURP procedure, they generally have they have a Foley that has that 3-way thing to it where you constantly have irrigation going through that. So they might be telling you about that and things that you need to watch for there. They're also going to tell you about if this person has a language barrier and if they have family or friends that are waiting, in the waiting room to see them or something. So ideally, the anesthesia provider should not leave the patient until the nurse is satisfied with their airway and immediate condition. So you want to make sure that this person is stable, because if they're not, that anesthesiologist is the one to help you, So they kind of like stay there for a little bit, make sure they're good, and then they go. Other things that you would do when they first get there, you would hook them up to everything. So hook them up to a heart monitor, give them a warm blanket, put oxygen on them, get a set of vitals, all of those types of things. Okay, so the way that I have this PowerPoint set up is kind of weird, but I basically just went through the chapter in the book and did it kind of like that. But so the rest of this is going to talk about things that you're going to watch for, things that you might be concerned about when they first come to the recovery room. So possible complications that you might see and what to do for those. And then we also talk about, some older adult considerations and, getting ready for discharge from the recovery room, like stuff you would need to do for that. So that's kind of where we go from here. So one of the first things that you're going to do is you're going to assess your patient when you get them, right? So after those people leave from the OR and you've already hooked them up to things, you're going to assess them. One of the first things you're going to assess is their airway. So airway is always your first thing. Think of your ABCs. So patients with prolonged anesthesia usually are unconscious with all of their muscles relaxed. This relaxation extends to the muscles of the pharynx. So when the patient lays on their back, the lower jaw and the tongue fall backward, and the air passages become obstructed. So this is called hypopharyngeal obstruction. So signs of this would be things like choking, noisy or irregular respirations, a decreased oxygen saturation, cyanosis of their skin. So if you notice this stuff as you're, assessing them, what you need to do is you need to reposition their jaw to open up their airway. So you're going to tilt their head back and push forward on the angle of their lower jaw. So like if you're looking at your face, at your jaw, it's like right by your earlobe here, that portion of your jaw, that's what you're going to get a hold of and pull forward. This kind of pushes the lower teeth in front of the upper teeth. And this maneuver pulls the tongue forward and opens the air passages. If you're worried that this person is too out of it still and they're not waking up quick enough and they need this help with their airway, then you need to put in an artificial airway for them. So I don't know if you guys have seen those before. Let me see if I can find a picture to show you what the heck I'm talking about. I'm going to stop sharing just a second. I just want to show you a picture so you know. Okay, see these right here? These are artificial airways. They come in a bunch of different sizes. These are the oral ones. So this would be something that, this person who can't maintain their airway, this would help with that. So this is like a plastic thing that it's real rigid. And when you put it in, you have to do like this twisting motion to get it in. And so when it's in, you see how there's this rounded portion? That rounded portion would be going down. It would like push their tongue down so that their tongue wouldn't be obstructing their airway. So that's kind of how that works. They also have nasal airways that you could do. The nasal ones, I don't think they're that great. These would probably be used more so than the nasal. But the nasal ones, they're not as rigid like this. They're more like flimsy-like, and they're long, and you put it in one side of their nostril, and it goes down, and it still keeps their airway open because it's so long. But it's just, I would think it would feel crazy. Same with this. You would never put this in on someone who's awake, right? So someone would fight you to all get out to try and get this put in, right? So always, when someone's not awake. Let me go back to our thing here. There we go. Okay, so again, airway is our first thing that we're going to be concerned about. So that's something that you could possibly see, and if that was a problem, then you would make sure that you put that oral airway in until they wake up enough to be able to take it out and they can maintain their own. Respiratory function is also something that you're going to be concerned about, so you're going to listen to their lungs. Obviously, we want to hear good airflow everywhere, and we don't want to hear crackles or anything like that. So we're going to watch for that. Then cardiovascular would be our next concern, because remember, when we say ABCs, airway, breathing, circulation is what the C is. So that's going to be your cardiovascular. So some of the things with the cardiovascular system that you might be concerned with. I'm going to flip to the next thing here. With cardiovascular, we're going to be concerned about if this patient is in shock. So that could be another possible complication that you might see post-op. So this is one of the most serious post-op complications. It can result from hypovolemia. What hypovolemia means is that you've had a decrease in your amount of fluid in your body outside of your cells. So like normally we have a certain amount of fluid. So if you've had blood loss and other things like that going on, then that amount of fluid is going to be low. So the most common kind of shock is going to be hypovolemic shock. So signs and symptoms of this would be they might have pallor, so they're going to be really pale. They're going to have cool, moist skin. They could have cyanosis of their lips and their gums. They could have a rapid, weak, thready pulse and narrowing pulse pressure. And what that means is the top number and bottom number of your blood pressure is getting closer. And then concentrated urine would be another thing that you might see with this. So if you did see this when they came to you in recovery room, what you would do is you would give them IV fluids and maybe infuse some blood products. So typically that's probably going to be what the problem is, and that'll work. But if that still didn't work, then maybe you would also give medications to help with their blood pressure to keep that up. So really the primary intervention for hypovolemic shock is just fluid replacement. That's all it is. So again, that would be something that we'd be concerned about with the cardiovascular system. Other things that we're going to be concerned about is going to be low blood pressure. So hypotension. This can result from blood loss, hypoventilation, position changes, pooling of blood in the extremities, or side effects of medications or anesthetics. So a systolic blood pressure less than 90 is going to be something that you're going to call about. Also, a previously stable blood pressure with a downward trend of 5 millimeters of mercury at each 15-minute reading should be reported. So in other words, you're at the bedside here and you have your monitor that you have set to just take vitals every so many minutes, right? And so at 15-minute intervals, if you see that your last few times have gone down, that's a problem. So you would call about that. All right, other things, dysrhythmias would be another thing that we'd be worried about. So this is, you'd have them on a cardiac monitor, so you'd be able to monitor from that. But a lot of times people will get dysrhythmias if they have electrolyte imbalances. So typically when they first get to you in recovery room, you have orders to draw blood and send that off for testing to see where they're at. And so if you see something comes back as low, usually if you replace that, that fixes the dysrhythmia. So a lot of times that's what the problem is. So you would be watching for those things as well. Another thing we'd be worried about is hemorrhage. So this means that someone's bleeding and it's bad. So usually you're going to treat this by giving blood products. The patient should be flat on their back with their legs elevated at a 20-degree angle. If the hemorrhage is suspected but can't be visualized, they could maybe even take the patient back to the OR to do an emergency exploratory surgery of the site. So, you know, it's definitely something that you want to keep an eye on. Other things that we're going to be concerned about, we want to relieve pain and anxiety. So typically as people wake up when they're in the recovery room, they're always like, oh, I'm in so much pain, you know. So that's a big concern for patients. So we want to make sure we take care of that. So IV opioids are going to be our primary thing that we do for pain relief. We want to watch for respiratory depression and drug interactions with those. We start with IV opioids because they, you know, provide quick relief and are short acting. Now, that's not the only thing that we do for pain anymore, because now that we have so many problems with opioids, with people becoming addicted and whatnot, we try to do other things to help with pain. So there is IV Tylenol that sometimes people will get, and that actually does help a lot more than you think it would. And it works quickly because it's IV. So, you know, there are quite a few things that you can do for pain. And then the other thing I have listed here is controlling nausea and vomiting. So again, even though the OR, you know, kind of watches that with you, sometimes afterwards when you start to wake up from your anesthesia is when it's a big problem. You don't want your patient to wake up and start vomiting, because that increased abdominal pressure that they get when they vomit is going to cause more pressure on your incision, and your incision could pop open because of that. So what do you think would be some things that would make you more at risk for post-op nausea? Is there anything you think would make you more at risk for that?
If you eat something, I mean, I know they tell you not to, but say somebody ate something before they procedure.
Okay. Anything else?
Having
Like an ulcer.
I didn't hear that. What was that?
I just said having motion sickness.
Yes, motion sickness. So if you have a history of that, that can make you more at risk for post-op nausea, believe it or not. And that kind of makes sense to me though, really. And then other people who would be more at risk for this would be females, more so than males. If you have post-op pain that's not controlled real well, that can make you nauseous. Dysrhythmias, so if you have a heart dysrhythmia, that can make you nauseous as well. So there's quite a few different things that can kind of play a part there. So yeah, we want to definitely control this as much as possible. So things that we reach for usually are going to be Zofran. Zofran or ondansetron is like the big thing that everyone gives now. Now, when I started practicing nursing years ago, they were doing Phenergan all the time, but they have come up with problems with Phenergan because, you know, sometimes it'll make people be too sedated and cause other issues. There is a medication called Vistaril that sometimes people will get that might help a little bit with the nausea too.
But that's more of a behavior meds, isn't it?
No, it does quite a few different things, honestly. It can help with nausea, but it's not generally just for nausea. It's for other things too. Yeah. Okay, so with older adults, we already talked about how they have less subcutaneous fat than the rest of us do. So they're going to be at risk for hypothermia after surgery. So we're going to really pay close attention to that. We also want to really pay good attention to them because a lot of times they don't have a really good nutrition status. They might be a little bit dehydrated to begin with, so now they're going to be even more so. A lot of times they have a lot of different comorbidities, so they can be really at risk for a lot of complications. Unfortunately, a lot of older adults can get post-op confusion and delirium. And I have on here, it can occur in up to half of all older adult patients. So it can be a lot of people that develop this.
Can you explain that? Does that mean that they like can't remember things?
Yeah, I'll actually talk about it on another slide here shortly.
Because I think I had a patient like that before. He had came out of like open heart surgery and he was totally different.
Yeah.
He was older. And the
Yeah.
family like was so shocked. And I was shocked too because I didn't know anything about it.
Yeah.
I was like, this can't be real.
No, it's definitely a common thing that you'll see. I'll talk about it more here in a minute and it'll make more sense, okay?
Okay, thank you.
All right, it's coming up on a different slide here, but let me finish going through some of this stuff first. So when we get ready to discharge someone from recovery room, so, you know, they've spent enough time in there, they are more awake, they're able to do things now, there is a scale that we can use. It's called the Aldrete scale. And this Aldrete scale helps us to be able to say, yes, this patient is ready to be discharged from the recovery room to a floor. So what we look for is their respirations. We want to see that they're able to take deep breaths and cough. So that we would give them a 2 for that. If they have a good oxygen saturation, so they're 92 or above, we're going to give them a 2 for that. If they're conscious and fully awake, we're going to give them a 2 for that. If their circulation is good, they have a decent blood pressure, we're going to give them a 2. And if they're able to move all 4 of their extremities voluntarily, we're going to give them a 2. So if you have an Aldrete score between 7 and 10, you can be discharged from the recovery room. So I have the chart right there on how they look at that. If you don't get a 7 out of 10, then you have to stay in the recovery room for longer. If you still are there after a certain period of time, if your condition doesn't improve, then they're just going to transfer you to the ICU, if that's the case.
And that is that normally more than the after the 7 days? Because you said they can stay up. Oh, are we talking about? Never mind. I keep messing them up because I'm going back to the one that you were saying that I thought you said patient could be up in their recovery for up to. No, that's 7 hours. Never mind.
Okay, it's okay.
I'm doing too much this morning.
It's okay. So you can be up in the recovery room for quite a bit of time, right? We said in the beginning that you can be there for 4 to 6 hours. So after those 6 hours are up, if you still can't get this patient stable and that Aldrete score is still low, then you're just going to transfer them to the ICU.
Gotcha. That's what I was. Okay.
Okay. All right. So this slide is talking about people who may have had just like a same-day surgery. You know, so they come in, they get something done, they recover in their recovery room, and then they go home. So anyone who has a same-day surgery, you cannot drive yourself home, you know? So patients need to be aware of that. You would not believe the amount of people who try to do that. Oh, well, I have my car out there. I don't have anyone to drive me home. Well, you should have thought about that, you know? So you make sure that they have someone to drive them home. And then when you give discharge instructions, you want to give them to both the patient and the people who are going to drive them home. Because the patient may not be fully aware of everything just yet, even though they're awake and talking to you, the anesthesia can still be messing with them a little bit. So you want to make sure they have a second set of ears listening to all of their instructions so they don't mess anything up. This person needs to limit their activity for 24 to 48 hours. So during this time, the patient should not drive a vehicle. They shouldn't drink alcohol. They shouldn't perform tasks that require high levels of energy or skill. And then if this is a person who is an older adult, when you give them discharge instructions and you print them out, a lot of times you will have the ability to make them bigger print so they could see it better. So you could do that. And then some places even have a way that you can print out discharge instructions in a different language. So like if it's someone from a different country that doesn't speak English, you could print it out in their language for them. So that's kind of nice too. But anyway, when you're discharging and you're giving instructions, you want to think of, if you had surgery, what are some things that you would want to know? And that's what you would include on these discharge instructions. So stuff like, hey, what am I allowed to eat? Do I have a special diet? What am I allowed to do for activity? Do I have to not lift a certain amount for a certain period of time? You know, what's my activity restrictions? If I have an incision, what am I supposed to do with that? Give me instructions on when I'm supposed to change dressings and give me dressing supplies. Am I allowed to shower? A lot of times people want to know that because sometimes they're restricted that way. And then, you know, you want to tell them things to watch for. So, hey, if you have chest pain or uncontrolled bleeding or this and that, come back to the ER. You know, you want to say stuff like that. And then if they have a follow-up appointment, you want to encourage them to come back for the follow-up appointment. A lot of people don't come to those, and it's just ridiculous. The follow-ups are really important because, you know, the surgeon can make sure that things are going like they should and that you don't have any, you know, problems popping up. And a lot of times if you have sutures or staples, that's when they come out at your follow-up appointment. So how are you going to get them out, you know? So those would be, you know, things to consider for the discharge instructions. Okay, so this part is talking about if you discharge someone from the recovery room and they stay in the hospital, they don't go home that day. So when you discharge them from recovery and they go to the floor, so during the first 24 hours after surgery, you are focused on trying to get them to get that anesthesia out of their system and get back to normal as much as possible. So that's kind of what our focus is when they get to the floor. So when they come out of recovery room to you, you're going to be taking their vital signs kind of often. A lot of times they'll tell you to take them every 15 minutes for the first hour, and then every 30 minutes for the next 2 hours, and then the temp is every 4 hours for the first 24 hours. So once the patient starts to recover from the anesthesia, the focus of care shifts from regaining independence with self-care and preparing for discharge. So again, we want to get this patient back to normal. So we want to encourage them to do things for themselves as much as possible. So as far as your care goes, like you get them from recovery room, they roll into your room on your unit, you put them on the bed, you do your assessment. So things that we're going to be assessing, we're going to be listening to their breathing, and we're going to make sure they're on oxygen, right? Again, we talked about vital signs. You're going to look at their skin. You're going to feel that and see if it's nice and cool, or is it warm, or what is it like? You're going to look at the surgical sites. You want to make sure you lay eyes on that. If they have a wound drainage system, you're going to take care of that. That may need emptied by the time they get to you. You're going to connect all drainage tubes to gravity suction or as indicated and monitor closed drainage systems. You're going to assess their level of consciousness and orientation and if they can move all of their extremities. We're going to assess their pain level because 9 times out of 10 when they roll down the hall to you, they're going to be like, when can I have my pain medicine? So yeah, that's their biggest concern. You want to know the characteristics of their pain, how long they've had it, what it feels like, all that type of stuff. Other things we're going to do, we're going to give them pain medicine. So we'll go get them something if we have it available right then and there. We are going to make sure they could reach their call light. So you put the call light close to them and you give them everything that they might need if you're not right there in the room to hand it to them. So if they need an emesis basin or ice chips or a urinal in reach, you put it all right there. And you want to position the patient to enhance their comfort. So if you can position them kind of up a little bit. That would be better for their breathing. You want to assess their IV sites for patency and infusions for correct rate and solution. So this is the thing. When they come from recovery room to you, they have different orders. So in recovery room, they have their own special set of doctor's orders that they are allowed to do for them. But then when they come to the regular floor, they have a different set of orders. So they might come to you on IV fluid, but it might not be the right IV fluid anymore. So you have to check your orders to see what is ordered, and then you may have to switch to a different type of IV fluid. Or, you know, like turn the fluid down or something. There's different things that can happen. We also want to assess the urine output in a closed drainage system, or use a bladder scanner to detect distension. I don't know if you guys are aware, but anymore, they don't put in catheters for every surgery anymore. They used to, but they don't now. So a lot of times people will come to you without a catheter and they haven't peed in hours. So they could be like super distended. So you may have to use a bladder scanner to see where they're at with that. We also need to reinforce the need to begin deep breathing and leg exercises, and provide information to the patient and family about all of this stuff. Oh, I did want to tell you a couple other things. I just saw something else on my notes here. So with urine output, you know how we were just talking about that. So urine output should be at least 30 milliliters an hour. So at the end of your shift, if this person has only put out, you know, a little bit, you want to call about that. So, you know, it has to be at least 30 milliliters an hour. So if you're there for an 8-hour shift, that would be at least 240 milliliters. So if you only had 200 milliliters, then you'd be calling. What else? Oh, so sometimes when they come to the floor, you may have to draw blood again. So hemoglobin and hematocrit levels often go down after surgery. This can be due to blood loss, or it could be due to dilution from IV fluids. So, you know, they will eventually go back up after the stress response from surgery subsides. So that's something just to keep in mind. All right, and then with the incentive spirometer, we do this to clear secretions and prevent pneumonia, right? So the nurse needs to encourage the patient to turn frequently, take deep breaths, cough, and use the incentive spirometer at least every 2 hours. Usually we say every hour while awake they do it, so they need to be doing it frequently. Okay, so this talks about different types of wounds. So wounds heal by different ways. So there is first intention, second intention, and third intention healing that we need to talk about. So most wounds are going to be first intention healing. Like, you know, probably 80% of wounds, maybe more than that, would be first intention. So first intention healing just means that the wound is cleanly made under aseptic conditions. It heals easily with little scarring. So you just have a wound that might be straight, it has sutures or staples, it's closed up from those and nothing is open. Doesn't have redness, nothing bad. So that's a first intention wound. A second intention wound. This would be where the edges are not approximated. So that's not closed, it's open. You get a lot of exudate from this, meaning that there's a lot of drainage coming out of the wound. And usually it's packed, and they might even have a drain inserted into it. So it could be like a wound vac or a Jackson Pratt or something that's in there. When I think of second intention healing, I think of things like maybe a pressure ulcer that they've had forever that is just really deep and open. So you know how certain things you can't like suture that closed anymore because it's just so deep. So it has to heal from the inside out. So as something heals by secondary intention, you're going to see granulation tissue form in there, and it's going to eventually close up that way. Third intention healing is very similar to second intention, but there's slight differences to it. So third intention healing means that the wound is even deeper than second intention. So it's really deep. And it's not closed up right away. So it has two surfaces of granulation tissue. So when you think third intention healing, you need to think about maybe someone who has a wound that's infected. So think of a person who might have gangrene. So maybe they have gangrene in their foot or something, and they're getting their foot amputated. This gangrene is so bad that the surgeon, when they cut off their foot, they're like, wow, there's still stuff in here. I'm worried that I didn't get it all out. So I'm going to leave this open instead of closing it up. And I'm going to let some of this drainage and yuckiness drain out for the next couple of days before I take them back to surgery and close it up. So again, third intention healing, it's a deep type of wound. Usually it's infected, it's open, and it's something that stays open because it was infected, and you're trying to get some of that infection to drain out, and then possibly in a few days they would come back and actually close it up. Does that make sense to everyone or no?
So the second one is just, you're not waiting, you're just packing.
Yeah.
And it's deeper. I mean, it is less deeper than the third one.
Yeah.
Okay.
Okay, this gets into a little bit about surgical drains. So drains are tubes that exit the peri-incisional area either into a portable wound suction device or into a dressing. This allows for the escape of fluids that could otherwise serve as a culture medium for bacteria. So most of the time, if you see a drain, it's usually going to be a Jackson Pratt drain like this. Other times, there are other ones. So sometimes there's Hemovacs, which are, they're a little bit bigger and they hold more. There also is another type of drain, which I don't know what the actual name for it is, but it's like an accordion type of a drain, that it has a long bag to it, and then the top of it you like squeeze together, and all of the drainage like sucks into there by having that, you know, sucked in like that. So that's another one that you might see. So anyway, when people come to your floor with a drain, you want to make sure that it's emptied, and you want to monitor what the drainage looks like. So you want to look at the color and how much they have and all of that type of stuff. So the color of it is usually going to be bloody. That's typically what it is. So that's a normal thing to see. As time goes on, you want to see the drainage get less and less in these drains. So as time goes on, sometimes the drainage color will change a little bit to more of like a yellowish color. That's okay. That's a normal color. So red or yellow are okay. Anything other than that is a problem. So if you get white drainage, if you get green or brown or anything weird like that, that's a problem. So you always look at the color and how much. We don't want to see a ton of drainage in their drains, you know? So like for these wound vacs, usually this holds, trying to think how much this holds. Maybe like a little bit over 100, I think. It's not a ton. So for people who are putting out a lot, that's a problem. So you want to make sure you call about it. The other thing you would do when they come to the floor, if their dressing around their drain is messed up, you would change that, you know, and make sure it's not wet or soiled. Now, as far as the surgical dressing, that's a different story. The surgical dressing, you need to keep and leave it there. So if this drain has to do with the surgical dressing, you wouldn't change it, you would just reinforce. So typically the surgeon is the first one to change the dressing. And then after that, you're allowed to do it. So anyway, you just need to make sure that it's not looking awful. So when they get to you, if it's saturated and full of drainage, that's a problem. So you would mark it, and you can mark it with a marker or a pen. Usually a marker is probably better. And then when you come back, you know, like say 15 minutes later, if you see that it's gone beyond that, you know it's a problem then. So you would call. You would be able to like reinforce the dressing too, if that was the case, you know, put stuff over top of it until someone comes to take a look at this person.
So when you say reinforce, it's not like you're making it stick better onto the patient. It's more like you can pad more stuff onto it and tape it around.
Yes, which
Okay.
I hate doing that. I always have. I thought it was a stupid thing to
Right.
do, but
It's
that's what they
yeah.
tell you to do. So that
Okay.
first dressing, they don't want you touching it and changing it. So
Gotcha.
if you have a ton of drainage on it, you just need to put more dressings over top and make it.
Okay.
Yeah. Okay, so we're almost done here. We've got a couple other things to go through. So we've got some post-op complications we're going to talk about, and then we'll talk about that post-op delirium some more too. Okay, so when we talk venous thromboembolism, this is something that people are at risk for post-op. So we need to get some more information about that. So what this is it's a blood clot that ends up happening, resulting in decreased blood flow to that area. It can cause you to have pain in that area. It could be swollen, you name it. So typically if you get a blood clot in your lower extremity, like your leg or something, you're going to have pain or cramping of your calf. You're going to have swelling, fever, chills, and diaphoresis that might be associated with this. A lot of times people will get a clot because they have pooling of blood in that extremity. This means that as you sit there for a certain amount of time, this blood just sits there and it's not moving. And so it causes it to clot. And so if this clot, lodges somewhere like that, then it's going to cause a problem. So our prevention for this is early ambulation. That's our number one thing that we could do. That's why we try and get people up right away after surgery. So when they come back to the floor, yes, we want them to get over their anesthesia and get their pain under control. So maybe they'll sleep for a little bit, but we want to get them up that day and have them ambulate. We also need to tell people about leg exercises. Leg exercises are really important. Even if you're on bed rest, you can do leg exercises. So this is, doing the foot pumps up and down, like going around with your foot, going up and down with your leg, any of that. That's going to help because it makes the blood not just sit there and coagulate. So you're moving, you're getting circulation by doing that. Other things that we can do. We want to encourage adequate hydration as well. And then don't put anything under the knees that can constrict the vessels under the knees. So those would be things to consider with this. For after surgery, we always have those SCD pumps, those ones that pump up and down on their legs. That helps increase circulation. We also do the sub-Q heparin shots, to help prevent this. There's quite a few things that we do. So that's what we're concerned about here. When we talk about hematomas, what this is it's bleeding under the skin, beneath the surface of the skin of the surgical site. So bleeding usually stops by itself and results in a clot in the wound. If the clot is small, the body will reabsorb it and will cause no problems. But if it's big, the wound usually bulges and the healing is delayed unless the clot is removed. So I used to work on a floor that had a lot of vascular surgeries, and they would do these surgeries where they would have an incision right in their groin area, and they would always have problems right there, always. So a lot of people would end up with a hematoma there, and so they would have to come and take care of this because it wouldn't be able to heal up otherwise. So what happens is the surgeon comes to the bedside, they take out a few of the sutures there, and then they evacuate the clot, they get the clot out, and then they pack the wound with gauze. And so healing would have to occur by secondary intention, right? So they pack the wound, and you would have to see that granulation tissue form in there. Now you can't like close it up again. So that's the hematoma. With infection, so infection, of course, we all know signs and symptoms of that, right? So, by doing a surgical wound, it disrupts the integrity of the skin, and you can, inadvertently get stuff in there. So if you get bacteria and things in there, it can cause all kinds of problems. So signs and symptoms of a wound infection. Of course, we're going to see swelling, warmth, tenderness, or discharge, incisional pain that's increased. We also might see increased pulse rate and increased temperature, and an increase in the white blood cells. So this is pretty similar to the hematoma. So one or more sutures or staples would be removed from the incision using an aseptic technique. The surgeon then separates the wound edges with a pair of blunt scissors or a hemostat, and then once the incision is open, they put a drain in there. If the infection is really deep, they may actually have to take them to surgery and do an I&D of that wound. So afterwards, antimicrobial therapy and wound care is initiated. So you have to do like
I have a quick question.
dressing changes quite often. Yeah.
What's I&D?
Incision and drainage.
Okay.
So basically, if the wound is so deep, if they went to the bedside to do it, they wouldn't get it all. So they would have to take them to the actual OR to go in and like reopen everything and get in to get all of that infection out. Okay, the next thing here is, I'm going to skip the post-op delirium because I'm going to talk about that last here. I'll talk about pneumonia for a second. So when someone gets pneumonia, it's an infection that inflames the air sacs in one or both of the lungs. So the air sacs may become filled with fluid or pus, and it can cause this person to have a cough and lots of phlegm. People are really at risk for pneumonia after surgery because they have a respiratory depressive effect from their pain medicine that they take, They also have decreased lung expansion because they're in so much pain. They're not moving as much because they are in pain or they can't, because of whatever they had done. So this is something that's a big problem. There is also something called atelectasis that is related to pneumonia. So atelectasis is where you have those air sacs in the lungs that collapse. They don't expand properly, and this can happen from an airway blockage when pressures outside the lung keeps it from expanding, or when there's not enough surfactant. So sometimes you'll see atelectasis happen before pneumonia. So atelectasis is almost like a precursor to pneumonia. So anyway, with pneumonia, some of the things that you would see with signs and symptoms would be, you would see either a decreased breath sounds over the affected area, or if it's really bad, you could hear crackles or sometimes rhonchi even. Pneumonia is characterized by chills and fever, tachycardia, tachypnea, cough. Sometimes you can see an increase in their temperature, their pulse, their respiratory rate. So things that we do for this then would be we encourage coughing and deep breathing. We encourage that incentive spirometer use, turning and positioning. So other stuff that we could do, obviously we're going to give them antibiotics because with pneumonia you need antibiotics to get rid of it. And then chest physiotherapy is something that we could do. Do you guys know what that is?
Yes.
So again, chest physiotherapy is a combination of three things. So it's sometimes it's positioning them differently in different ways to kind of get some of the drainage in their lungs to move so that it's easier to cough up or suction out. That's one of the things. Another thing that goes along with that is that cupping, where you kind of like smack their back in certain areas to try and get some of that secretions loose to get it out. And then the third thing would be like if you were part of respiratory would put like a vest of some sort on you that like shakes you, and it helps to get some of that stuff loose as well. So that is all chest physiotherapy. And then of course we could do breathing treatments as well for pneumonia. And then with altered bowel function, everyone ends up having problems with constipation after surgery. So this is due to decreased mobility, decreased oral intake, and also taking opioid pain medicines. So for prevention, we want to frequently assess their bowel sounds. Are they distended? Do they sound hypoactive? And then we want to treat this by doing early ambulation, improved dietary intake, stool softeners, and use that 3-day rule. So if it's been 3 days and they haven't gone yet, give them something. So give them a laxative or something. All right, and then with post-op delirium, let's talk about that. So post-op delirium is going to be something that happens where this person will get confused, and it's not something that is going to last. Like once you figure out what the cause of it is, then you fix that cause and then the confusion goes away. So it's like a short-term confusion. So there's a bunch of different things that could cause it. I have a list of things here, but there's probably even more than this, more than what I listed. There's a lot of things that can cause it. So if this person just has some kind of acid-base disturbance, that could cause it. If they are a drinker and they're going through alcohol withdrawal, that could cause it. If they're dehydrated or have a fecal impaction, that could cause it. Hypoxia, infection, urinary retention, all these things. So basically, you want to treat the underlying cause. So once you do that, it'll fix it. It will improve. So things that put people at risk for delirium would be increased age, history of alcohol abuse, whatever their pre-op cognitive function was, like if it was already lower as it is, then that's going to put them more at risk. If their physical function isn't very good, that might put them more at risk. So yeah, so some of those things. So when we see someone with post-op delirium, this is what it's characterized by. So not only are you confused, but you have perceptual or cognitive deficits, you have altered attention levels, you have a disturbed sleep pattern, and impaired motor skills. Older adults recover more slowly from surgery, and they are at greater risk for developing post-op complications. So one of these is this delirium. So some of the things we can do to help with this, we want to keep the patient in a well-lit room, close proximity to the staff. So if at all possible, move them to a room that's like right across from the nurse's station. Restraints should be avoided because they can worsen the confusion. Engage the patient in conversation and care activities. And also remember that pain can contribute to delirium, so make sure to medicate. So a lot of times I think people don't choose to medicate people when they really need it, and that's part of the problem. Questions? Hopefully that answered your questions about delirium a little bit. Okay, so I want to just hop onto the Canvas page here a second. So when you're looking at Unit 1, remember I always have readings up at the top, and then I put videos, and then I have the PowerPoints after. So other things that I might have would be handout type things. So like here I have pre-op checklist, day of surgery, drains and suture care. This range disorders thing has to do with pain medicine. So that would be something to look at. And then I have principles of sterile technique. So make sure you're looking at some of these handout type things too. And then I do want to talk just a little bit about pain. I'm not going to pull up the PowerPoint. There is a PowerPoint here. You guys can look at that. But let's just talk a little bit about pain and make sure we're all on the same page about stuff that you think would be important to know about pain. Just so you're aware, in your ATI book, there is a pain chapter. You have one in your fundamentals ATI and you have one in your Med-Surg ATI book. In the Med-Surg ATI book, it's chapter 4. So definitely go look at that. So some things I want you to really pay attention to as far as pain goes would be like the different types of pain. So what do you know about the different types of pain? What's the difference between acute and chronic?
Chronic is longer than 6 months.
Okay.
And time. Acute is only for a short time.
Yes.
So it's like a sudden onset.
Okay. So if someone has chronic pain, what are some things they might be at risk for?
Infection.
Depression.
Depression. That's what I'm looking for. So think of someone who might have like chronic back pain. If you live with that every day and you constantly have that pain and it's not really taken care of very well with no matter what you do, that'd be depressing, right? So that's something that I think a lot of people forget about is that depression. So they might be more at risk for like suicide and things like that, you know? So keep that in mind. What is nociceptive pain?
2.5 hours.
What's nociceptive pain?
That's like organs, the organs.
Okay.
Pain that's like somewhere like you. I'm trying to figure out how to say it. It's separate somewhere else. If you feel it somewhere else, but it's related to a different, like an organ, a specific organ. Is that right?
Kinda.
Did I explain that right? I don't think I'm explaining it right.
You're kind of right, kind of not.
Can you explain it?
Anyone else want to take a stab?
I thought nociceptive was a specific injury or I can't think of the word now. That went right out of my head. Sorry.
That's okay.
Nociceptive, is that neurological?
No. So
I had to write about organs.
Sort of, yeah.
You could just explain it.
It's okay. It's fine. So nociceptive pain is going to be damage or inflammation to tissues other than the peripheral or our
That's what I
central
said.
nervous
I
system.
said tissue pain,
So
but I thought I was wrong when she said organs. I was like, well, maybe it's not tissue.
it is tissues. And then there's different types of nociceptive pain. So that's where you're coming into play with the organ pain. Okay. So when you talk organ pain, we're talking visceral. Visceral pain is a type of nociceptive pain.
That was the word I was looking for.
Yeah. Yeah.
It's two different ones, right? It's visceral and something else.
Yeah.
Can you give examples of them?
Somatic is the other one you're trying to think
Yeah.
of.
Okay.
Yeah.
Are you able to give examples?
Yeah. Yeah.
Okay.
So when we talk visceral pain, it's internal organ type pain. So like maybe I have stomach pain, or my appendix is getting ready to burst or something. So it's, that type of pain.
Mm-hmm.
Somatic pain is like in your bones or joints or your muscles or something like that. And then we all, I think, kind of know what neuropathic pain is, right?
Is it like a toothache, like when you get a nerve
pain?
Yeah, it's
nerve pain.
Nerve pain.
Peripheral nerve pain.
So if you, I don't know, say you had to get an amputation. So people who get amputations get this type of pain because they cut through nerves when they amputate your extremity. So yeah, neuropathic pain has to do with your nerves. Okay, when we're assessing someone in pain, what are the things that we assess?
Duration.
Yeah.
Duration. What else?
The type of pain, so like if it's sharp or dull.
Okay. What else?
On a scale from 0 to 10, like, so the strength of pain.
Definitely. So I think people kind of know this, but they don't always go through all of the steps of this when you assess someone's pain. So you always want to know, where is it? What kind of pain is it? So tell me, is it sharp, achy, throbbing, whatever? What is the number on a 1 to 10 scale? So you're doing that to see how bad it is. Is there anything that makes it better or worse? That's something that a lot of people forget to ask. So you need to know that. Is there anything that is like an associated thing along with your pain? So do you get nauseous along with your pain, or is there anything else that happens along with it?
Would you say like radiating pain?
Yeah, you could also say that.
Mm-hmm.
So you have where, what, the number of the scales, anything that's better or worse with your pain, and associated, anything that is associated with the pain.
Yeah.
Okay.
Okay, other things to think about with pain. We also want to think about the things that we give people for pain. So, hey, we have non-pharmacological things that we can do. We also have pharmacological things we could do. So what are some non-pharmacological things we could do?
Repositioning the patient.
Music therapy.
TV, engaging in conversations, back rubs.
Ice.
Okay. Anyone tried anything unusual that has helped with their pain before?
Biofeedback.
Okay. Can you explain that a little bit?
Basically, because I actually do have chronic back pain. Basically, how they describe it to me is like, it's kind of like an out-of-body experience. Like you try to just like envision like a place that you'd rather be. It's basically like distraction.
Okay.
And like the beach or something, you can like imagine like the waves, just stuff like that.
Okay.
Would that be like meditation too, or is like a different term?
Yeah, they're slightly different, but yeah, it's
Okay.
similar.
Okay.
Has anyone ever used a TENS unit before?
I have.
Did you like it or no?
No, I did not like it.
So,
What is that?
A TENS unit is something that you can hook up to your body. Like for her, she said she has back pain. So like when you get a TENS unit, you can actually get them over the counter anymore. It might have like a sticker type thing that you put on your body in that spot that's hurting you. So if it's her back, she's going to put it on her back. And then it has like little, I don't know if you want to call them electrodes, but like little electrode things that come off of it. and it's hooked to a little device that like sends these pulsations into your body. So you can set it different ways. So like it might pulsate frequently, or it can do it slower, it can do it for longer. Some people like them, some people don't. You know, I'm sure the ones over the counter aren't as good as the ones that you would get from like a physician or something, but they're kind of cool. So that's another option.
Would cupping therapy be one?
Maybe, yeah. But yeah, so that's kind of non-pharmacological things. So then when we think pharmacological, if we're not giving opioids, what are we giving?
Tylenol.
So like the NSAID stuff, right?
NSAIDs.
So what do you know about NSAIDs?
They help with inflammation, so it will help with the pain.
Okay.
They're like blood thinners.
They can cause bleeding, definitely. Anything else?
It's like ibuprofen, naproxen, stuff like that.
And
They're very hard on the stomach and shouldn't be given to gastric bypass patients.
Yes, yes. So generally, NSAIDs are going to be given to people if they have mild to moderate pain. So generally, it's not the first thing you're going to reach for if they have severe pain, right? So something that people don't always remember is that they can cause bleeding, for one. That's a big one. You can, like she was saying, you know, they can be really hard on your stomach, so they can actually cause ulcers and things. And then they also have some hepatotoxic effects. So they can be hard on your liver. So if you have someone who has liver issues, they shouldn't be taking that, right? So those are some things to remember about NSAIDs. A lot of times you will see people be given NSAIDs and opioids together. Why would we do both?
Would you give the NSAID between the time, because opioids are only during certain times, so you can't give too many or too much in the 24-hour period, so you would give the NSAIDs in between.
Yeah, you could give them in between. So the thing is, though, a lot of opioids have what in them?
Acetaminophen?
Yes. So if we're talking acetaminophen, you have to be careful, you know, what you're giving in between, so you're not overdosing with acetaminophen, right? But yes, you're correct. So if you, like, if someone's on Percocet every 4 hours, well, maybe that's not enough. You know, maybe their pain is so bad that they still get breakthrough pain. So if you have them on a schedule where you do the other stuff in between the every 4 hours, then usually that, you know, takes control of their pain a little bit more, right? All right, what's
your residents get mad at you when you do, like they have a problem when you're trying to explain that to them and they don't get it, and they're like, well, I want it, this nurse gave it to me last time, but why can't I get it? So
I know.
it's kind of hard.
People are something, aren't they?
Yeah.
I totally agree with you. All right, tell me about opioids. What do you know about opioids?
Highly addictive.
Okay, what else?
Causes constipation.
Okay.
They
I
cause
feel-
pupil constriction.
Okay. I feel like everyone always concentrates on the constipation with opioids. Like that's the big thing. So there's other things that I want you to make sure that when you're thinking opioids, you think of first before you think of constipation. What's more important than constipation?
Respiratory rate.
Respirations.
Yes.
Respiration.
So they can cause respiratory distress. So that's like the most important thing to really remember about opioids. So if you see a question and it has multiple things in it, if you have to choose between respiratory depression and constipation, respiratory depression is more important, right?
This is the breathing first, right?
Yes, yes.
Okay, gotcha.
I have a question.
Yeah.
So normal respirations are 12 to 20. If you were to give an opioid to a patient and the respirations were always like at a 16, 18, and then all of a sudden they drop to like 13 or 12, would you consider that a big drop in respirations, or would you just continue like monitoring, or?
You would just monitor because they're technically still in the okay range, even though they've dropped some. They're still in an okay range, so you would just monitor. And once it started to get in the not okay range, then you know, hey, I can't give anymore.
Okay.
All right, other stuff. So we already mentioned constipation. We mentioned respiratory depression. What else can opioids do to you? There's a few others that we're not. Yeah, but that's not one of the big adverse effects.
Doesn't it decrease your blood pressure?
Okay, so orthostatic hypotension, right?
Okay.
And then what else?
It can make you nauseated.
Yep, that's a good one. And there's two more that we're forgetting.
Can you say that one more time? I was taking care of, I know I'm not supposed to, but my niece needed me for a second.
Okay.
I just didn't know the question to
So
contribute.
we're trying to think of some adverse effects of opioids. So there's like 6 big ones. And we've mentioned 4 so far, so we're missing 2.
Is it substance abuse?
No.
Okay.
So one of them is pretty obvious that you guys are forgetting, sedation, right?
Mm-hmm.
So when you take an opioid, it'll sedate you, it'll make you go to sleep probably, right? So that's one. And then the one that everyone always forgets is urinary retention. So definitely know those 6 adverse effects. Those are super important to always remember, okay? Because especially with surgery stuff, when we're giving people stuff for pain, it's usually an opioid. So those are the things that we need to be thinking about, okay?
I have a question.
Yeah.
So, is opioids, do they act on the parasympathetic system? So they should they relax the urinary, system? I don't know if that makes sense. Because I'm just thinking like urinary retention, wouldn't it be the other way around? Maybe. I don't know if I'm asking the right question.
So no, they do cause urinary retention. So you are not able to get all of that urine out. I know you, I get what you're saying. It's hard for me to explain why, but yeah, urinary retention is definitely something that opioids do. So
is that because of the anticholinergic effects?
I think so, yeah.
Yeah, because it's
okay.
So I got urinary retention, sedation, orthostatic hypertension. What was the other 3?
Constipation, nausea, vomiting, respiratory depression.
Okay, thank you.
Okay, you guys have heard the term adjuvant analgesics before or not?
The term
no.
Adjuvant?
I haven't.
Okay, what this means is there are certain medications that we can give along with opioids and NSAIDs that can actually help with pain as well. They may not be specifically just for pain, they could be for other things, but when you give them in addition to those other stuff, it helps with their pain better. So like, for example, anticonvulsants, anti-anxiety agents, sometimes antiemetics, sometimes antidepressants. There's certain antidepressants that actually help with pain, So you wouldn't give that just by itself, because by itself it's not going to do what you need it to do, but giving it with those other things, it actually helps. So just keep that in mind. So like, when someone gets, I'm going back to that whole amputation thing. So if someone gets an amputation and you give them, their opioids for their pain, and maybe you have them on other stuff, but they're still having that phantom pain. you can give other things to help with that. And that's some of these adjuvant things. And usually that takes care of it really well. Okay?
So are you talking about the antagonist, Angelus? Like, is that the term you're talking about? Because I didn't really fully hear you.
No. When you look in your ATI book, you'll see how it's spelled. It's adjuvant medications. It's just
Okay,
different type of medications that normally you would give for other things, but when you give them in addition to your, opioids and other stuff, it just helps with the pain better.
Okay, thank you.
You know how a lot of people take gabapentin?
Yeah.
So gabapentin would be an adjuvant medication.
Okay, is that because it's used for the blood sugar and neuropathy?
Gabapentin's not used for blood sugar.
I mean, for neuropathy?
Yeah.
And the pain?
Yeah.
Okay.
You consider them like muscle relaxers too?
I take gabapentin for fibromyalgia.
Yeah. Yeah. I mean,
okay.
It's used for a lot of different things. Yeah.
But my doctor gave it to me because she said too many physicians were prescribing like opioids for fibromyalgia and adding to the addiction problems. So she used that instead because what fibromyalgia is, it's misfiring of your pain neurons, and so that helps to block that so you don't get the pain.
Right.
Would you consider another one like a muscle relaxer since it relieves pain?
Yeah, that could be one as well. Mm-hmm.
Okay.
All right. And then I can't remember specifically right at this moment if you have anything about PCA pumps on your test, but like for PCA pumps, so patient-controlled analgesia. So a lot of times when people have surgery, they are put on a PCA pump afterwards. So what this is it looks like an IV pump, but it's slightly different. It has a different piece to it. So you have this big long syringe that's like a 60 cc syringe that has, either morphine or Dilaudid usually in it. And that is put into the device. And then the way that it's hooked up, the patient can push the button every so many minutes to give a certain amount of pain medicine to them. So something that you guys need to know for like testing purposes would be you don't want to see any like relatives pushing the button for them. Okay, so you want to make sure that family members know that that's not their place to be doing that. The problem is this is an opioid, right? So if this person is sleeping and their family's like, oh, well, if they don't push the button, when they wake up, they're going to be in a lot of pain, so I'm just going to push it for them. Well, if they keep doing that, they can overdose, They can cause respiratory depression. They can cause problems, right? So we don't want to do that. So we definitely want to make sure family members stay away from pushing that button.
Are we supposed to be seeing something or no?
No, I'm just talking.
Okay, you're just talking. Okay.
Yeah. Okay. What would you say to a patient who is worried about getting addicted to pain medicine after surgery? Like if they're not wanting to take their pain medicine?
Do you give them like non-pharmacological options?
Well, so I want you guys to know that, yeah, I get the whole thing about being addicted to opioids. That we get it, and we know it's a huge problem everywhere. But the thing is, it's important for them to still take their pain medicine right after surgery, especially right after surgery.
Educate them?
Yeah, we want to educate them because if they're taking it like they're supposed to, like it's scheduled, then they should be okay. And then as time goes on, like as you get a little bit further out from the surgery, you can decrease the amount that you take. You don't have to take it as often, or you don't have to take it as much. But that first week or two, it's really important to be taking it, because if you don't, then your pain gets way out of control. It's hard to get it under control. Then you aren't able to like cough and deep breathe like you're supposed to. You're not able to get up and walk and do stuff. So you have to be able to do those things. And so that's the only way you're going to be able to do that. Do you guys understand what I'm saying?
Yes.
So just remember that, because that's kind of an important topic that a lot of people just don't quite get. Now, with addiction, like you have to be taking something for a while to really get addicted to that. I did have a coworker of mine who had, I think it was back surgery she had, and they had her on Dilaudid afterwards, and they just like overdid it with giving her the Dilaudid, and she did end up coming addicted to it. So, and this was like over a period of time. It wasn't just like right after surgery, but you know, for a while. Like she was taking it for too long. I think that's all I'm going to say about the pain stuff. I mean, you guys can go look at that PowerPoint. That PowerPoint's huge. It has a ton of stuff in it. We don't have like 3 million questions on pain on our test, so there's just a few. So just, you know, review some things about it. Make sure you feel good about those types of questions, okay? So next week, when we come back on Tuesday and Thursday, we'll be doing, you know, the math test, of course. So make sure you guys all go and do that practice math test that I gave you. If you have problems, make sure you let me know and I can try and help you out with what you need to do with that. Next week, we're going to be getting into orthopedic stuff, so you can start looking at that if you haven't already. Okay? Does anyone have questions about anything that's due next week as far as stuff that's due?
I do. Me too. Can you just tell us everything that's due? Give us the rundown.
Well, I mean,
read.
It's on your syllabus.
Not like that, but you know what I mean.
I'm not quite sure what you're asking me.
Like, when is the ATIs due? Like, what day is that?
It's on your syllabus. Just look at your syllabus. I have like more than one class. I can't remember when everything is due off the top of my head.
I believe it's the 16th.
Okay, thank you.
I think it's the 16th, and that's worth 10 points if I'm looking at it correctly.
It's on the 16th, yes.
Yes, okay, thank you.
Okay, I mean, I just didn't understand. I must have misunderstood your question when you said.
Oh, you have so much thinking about, man.
No, I'm just asking if you had questions about the stuff that's due. So you guys haven't.
So I do.
You guys haven't turned in anything for me yet, so that's why I'm asking.
I have a question. So for the remediation, how do we access the remediation? Because I've never had to do that before. So I just want to make sure that I'm clear on how to access the remediation part of it.
The templates?
Uh-huh. Yes, ma'am.
Okay, hold on one second. I'll pull it up real quick.
Yeah, that was my question. It came out. It's hard to hear you when I got my things going on in my background, and I don't have my
If
my
you go
laptop
on
is
your
updated right now.
If
So
you
I
go
don't
on
have to
your
pull it up.
ATI at the very top, there's 2 sections and it says active templates. So click on that and it'll have all the templates there.
Yeah. So
And
it's there, and I also put it on our Canvas. So look at your screen right now. Under modules, there's a section that says examples, and look here. Here's some active learning templates right here.
And we can just open those up and then use those, and we don't have to go to ATI?
Yeah, either way. I just put them on. I just put them on here to make it easier.
Right. So
Okay,
if they
thank
say
you.
do 6 templates, you're doing 6 of these templates, right?
So,
like, you know how they say do 5 or...
So look. You tell me if you see this or not. I may have to open it up again.
I do.
Okay, so here's that one example I was showing you guys.
Right.
So if you had to do 6 templates, you look at your topics to review, and you pick
Okay.
6 things that you want to do. So it tells you what template to do. So like if you picked this one, delegation and supervision, it tells you you need the basic concept template.
Oh,
You see what I'm saying?
okay.
If you did this one, information technology, that's a systems disorder one.
Gotcha. Okay.
I have a question because, and I'm sorry, maybe already went over this, but seriously, I'm sorry. So when we go to ATI, I went to ATI, do we just go under the adult section?
To find the targeted assessments, or what are you talking
Yeah,
about?
yes, that.
All right, here, let me see if I can pull up that. Let's stop this a minute. If no one else has questions, you guys can go. Whoever has questions can just stay. You don't have to sit here and listen to all this if you don't want to.
And I just need to, because I get the template part, like the remediation. I just didn't know where to find the ATI.
I have a question. While you looking up the ATI, are we doing the ATI, the remediation for all the ATIs or just the proctored?
So the proctored and all of the other assessments. So every one of them you're going to do it for. The only things you will not do that for would be the module stuff that you have to do. The modules are different.
Okay.
Let's see. I'm just trying to change this to student view so I can look like what you guys would see when you get on here. Okay, so you would go to My ATI.
Mm-hmm.
All right, and then you would look down through here and see what you, or actually maybe it's under test. Let's look under test. So see how you have learn, test, improve. It might be under test. Let's see. Yeah, here we go. So like for the fundamentals, practice A and B, you know, those would be here. Like you have to go to the 2019 though. Here's the 2016, so you would want the 2019. And then all of the targeted things should be on here as well. So see here's targeted endocrine, targeted.
Thank you.
So that's where you find it. So again, you're just under My ATI and you go to test, and then that stuff should be in here.
Thank you.
Thank you.
And then for those of you who wanted to know where the templates were on ATI, look right here up at the top of the page, just right beside study materials. Here's active learning templates. Okay.
All right. Thank you.
Uh-huh.
Have a good day.
All right. Any other questions, or everyone good?
Is there a Dropbox for like the clinical paperwork that we're turning in? Is there a Dropbox under your
in Canvas? Yeah.
Canvas. Okay.
Do you want me to pull it up?
Yes, please.
Okay, so when you're on our Canvas page for my class, over here on the left, you see where it says assignments? If you click assignments, there's a bunch of things here. So see, here's VSIM. Here's those concept labs, you know, for the shadow health stuff. See all that? That's where those are.
And I had another question. I'm sorry. Where do we find? I saw that we had orientation due for the DocuCare.
Are you sure it's DocuCare and not Shadow Health? Does it just say DCE orientation?
You know, that's what it says. DCU orientation. Where?
That's the Shadow Health.
Okay.
Yeah, so did you already have clinical this week?
Yes.
What did she have you do this week? Did she have you do shadow health or did she have you do the VSIM?
Just the VSIM.
Yeah, so don't worry about it this week then.
Okay.
The DCE orientation thing can be done next week. It
Okay.
was such a cluster on Monday because nothing was made available to people. So I've had people just skip that week and do the second week first, and then next week you guys will go back and do that stuff.
Okay.
All right. Anything else? Okay. You guys have a good rest of the day.
Thank you.